Good morning, everyone, and welcome to today's Lights, Camera, Action Future of Public Health Summit. For many of you, this may be a welcome back because you attended one of our three earlier summits. The first focused on workforce, the second featured a discussion on data modernization, and the third summit explored public health law and finance. So to review previous summit materials, in case you missed them, the recordings are on futureofpublichealth.org. Today is focused on another topic in the Bipartisan Policy Center's Public Health Forward, Modernizing the U.S. Public Health System report, catalyzing multi-sectoral partnerships and community engagement. Health at all levels has engaged in partnerships for decades, and we want to celebrate this great work. One of the 10 essential public health services is to strengthen, support, and mobilize communities and partnerships to improve health. In addition, public health accreditation emphasizes the importance of partnerships and community engagement. And Public Health 3.0 calls on public health leaders to serve as chief health strategists, partnering across multiple sectors and leveraging data and resources to address social, environmental, and economic conditions that affect health and health equity. The vision described in the Public Health Forward report is of diverse partners working collaboratively toward a shared goal of providing a fair and just opportunity for all to achieve good health and well-being. Beyond partnering across sectors, effective community engagement drives public health to prioritize the right interventions, policies, practices, and approaches to community-driven health priorities with community-driven approaches. These can and should be informed by people who have experienced health inequities and by communities that may not have been consulted in the planning of public health activities. This means putting communities in the driver's seat and establishing trust and strong relationships with the community. As one example, Public Health Forward recommends that partnerships between public health departments and other sectors, such as housing, food, transportation, and stakeholders like businesses, faith-based organizations, and healthcare are incentivized. So how do we make this happen through funding and structures? How do we define the incentives? Public Health Forward also recommends policymakers allocate funding to support the development and maintenance of partnerships that aim to provide a fair and just opportunity for all to achieve a good health and well-being. The report also advocates public health departments clearly delineate shared goals, responsibilities, and collaboration guidelines for decision-making, conflict resolution, and data sharing, using this body of work as a foundation for sustainable collaborations. These collaborations could include sectors within a single community coming together to address clean water issues, or it could be the global community collaborating as they did to eradicate smallpox, the first and only disease to be eradicated. Or thinking about our current events, I think we can all imagine the multi-sector partnerships that will be needed to address the heartbreaking refugee situation in Ukraine and neighboring nations. Not all multi-sector public health partnerships will have a grand global scale, but that doesn't mean that they're less important or impactful. A community working to address food deserts or access to healthcare could be incredibly transformative for the people living in it. As we think about partnerships, it's also important to not only bring sectors together, but also to do it in such a way that it has lasting impact. That's what the Milken Institute Center for Public Health advanced recently with the release of their report titled Learning from COVID-19, Reimagining Public-Private Partnerships in Public Health, that called for a new model of partnerships focused on public good to create and sustain value in public health. The Milken Institute report analyzed COVID-19 lessons learned and uncovered three thematic areas where partnerships for public good present opportunities to strengthen public health. The areas they put forward are 1, human capital, 2, logistics, and 3, data infrastructure. It's important to recognize, though, that partnerships can come with challenges. As the Milken Institute report continues, beyond culture class, partners often aren't aligned on goals, implementation, nor in sync on how success and accountability are measured. This type of mismatch can sometimes occur when bringing together public health business. In fact, we know there are many in the public health community, as well as their counterparts in business, who are skeptical of working together. But we need to move beyond that skepticism. As a de Beaumont Foundation report titled Business and Public Health, Working Together for More Prosperous Communities emphasizes. They note for real change to happen in public health, the business community needs to be a driving force. Building on that thought, the de Beaumont Foundation and the Johns Hopkins Bloomberg School of Public Health put forward 7 practical steps that businesses can take to align with public health for bold action and innovation. These steps range from putting out the fire of the COVID-19 pandemic to improving the well-being of employees with earned sick leave, to advocating for the development of accountability dashboards that track and monitor the progress toward achieving key economic and public health outcomes in a community. As we focus on the power of partnerships, it's critically important to focus on the central role that authentic community engagement plays in achieving health equity and vibrant, healthy, resilient communities, essentially what public health mission really is. So as we engage with our communities, we need to be mindful of power between partners and realistic about the history surrounding the treatment of many communities, which has led to incredibly challenging health equities. But I believe we can come together with these challenges. I'll return to the Bipartisan Policy Center's Public Health Forward report that put forward an ideal vision for the future when it comes to health equity. In looking ahead to 2026, it stated advances in health equity continue to be made because public health departments partner with various sectors and community members, and also engage in tribal consultation toward the shared goal of providing a fair and just opportunity for all to achieve good health. And so today, I look forward to learning from you on what makes good partnerships, including good ideas in action. In this regard, we'll hear about creative partnerships to tackle COVID-19, antimicrobial resistance, and the complex challenge of homelessness. And we'll learn lessons from each other. So as we get started this morning, I want to recognize our partners, United Health Foundation, the Robert Wood Johnson Foundation, and the Pew Charitable Trust, for stepping forward to provide initial support for the Lights, Camera, Action Summit series. Their support is helping to catalyze activities needed to propel positive action, rebuild confidence, foster health equity, and transform our nation's public health system. I want to also acknowledge our co-hosts, including the Association of State and Territorial Health Officials, or ASTO, the National Association of County and City Health Officials, known as NACCHO, and the Big Cities Health Coalition. So now let's get started. It is my honor to welcome and introduce Dr. Rochelle Walensky, who is Director of the Centers for Disease Control and Prevention. She joined us for our first summit, and we're very pleased to have her back again. Dr. Walensky became the 19th Director of CDC and the 9th Administrator of the Agency for Toxic Substances and Disease Registry in January 2021, after serving on the front line of the COVID-19 pandemic as Chief of the Division of Infectious Diseases at Massachusetts General Hospital and Professor of Medicine at Harvard Medical School. Dr. Walensky is an influential scholar whose pioneering research has helped advance the national and global response to HIV/AIDS. She's also a well-respected expert on the value of testing and treatment of deadly viruses, and has conducted research on vaccine delivery and strategies to reach underserved communities. Dr. Walensky is joining us today by video.
Thank you, Dr. Monroe. I'm delighted to be back at this summit. The series has been a tremendous success, and I am encouraged by the robust dialogue and innovative ideas that have emerged from each of these sessions. My thanks to the CDC Foundation for bringing us together. For this final summit, we have gathered to talk about partnerships and the critical role they play in our current and future work in public health. Indeed, it is partnerships that will help us build a diverse and effective public health workforce, improve the quality of data and how we share information, and strengthen public health law, governance, and finance. With partnerships, 1 + 1 can often equal 5 by amplifying resources, reaching more people, gathering like minds to work for the public good. Partnerships should be developed early so the foundation is in place long before you might need to rely on each other in an emergency. And we must always remember that partnerships are not a one-way street. Indeed, partnerships work best when you have something to offer each other. Partnerships with our colleagues in public health, with professional organizations, with businesses and philanthropic entities, with private individuals and groups, all help federal agencies like CDC build on the strength of others. We have found that engaging partnerships can lead to innovative strategies and can change the way CDC conceptualizes and solves problems. Partnerships provide opportunities for both formal and informal collaborations that lead to valuable mutual benefits. Because partnerships are so valuable, we have developed strong partnership policies and processes to be sure that we always maintain public trust, adhere to CDC's core mission, and provide accountability. Let me share just a few examples of partnerships that have made a difference for CDC. As we began to ramp up COVID-19 vaccine delivery and administration and needed to get vaccine to all parts of the country, whether big city or rural community, we needed a way to make it convenient for people to get vaccinated and to provide vaccination in a setting where people would find trusted messengers. Through the Federal Retail Pharmacy Program for COVID-19 vaccination, the federal government partnered with 21 national pharmacy chains and independent pharmacy networks to administer COVID-19 vaccines in communities across the United States. About 90% of Americans, including people who live in hard-to-reach and rural areas, live within 5 miles of one of the more than 41,000 participating pharmacies. Since the program's launch, pharmacy partners have been using CDC's Social Vulnerability Index when deciding where to invest resources. Pharmacies have used creative approaches to reaching vulnerable communities, including off-site clinics, special hours, and clinics for workers unable to get to a pharmacy during normal business hours, partnership with rideshare companies to allow those with transportation restraints to get a vaccine appointment, and engagement with community and faith leaders who are trusted messengers in their communities. Since the beginning of this program, 43% of the doses administered through the Federal Retail Pharmacy Program have gone to a person from a racial or ethnic minority group, for those for whom we have data on race and ethnicity. The Federal Retail Pharmacy Program relies on a close collaboration between pharmacy partners, CDC, and state, local, and territorial public health departments. States and territories have access to the program data, including ordering data and inventory levels for retail pharmacies in their communities, and are engaged in ensuring the program helps meet their public health goals. And when we needed to roll out our booster campaign last fall, our partnership with the Federal Retail Pharmacy Program was key. For example, by linking retail pharmacies with nursing homes and long-term care facilities, we were able to deliver and administer boosters to those most vulnerable. As of mid-March, pharmacy partners have completed over 8,000 clinics and long-term care facilities and administered more than 500,000 booster doses during those clinics. To get vaccines to agricultural and migrant farm workers, we relied on partnerships again. The transitory nature of the work and the lack of a medical home for most of these farm workers, coupled with low vaccination rates in rural communities in general, meant we needed partners to help us get the vaccine where it was needed and to serve as trusted messengers with culturally appropriate communication. Since January 2021, CDC's Vaccine Task Force engaged in local and national outreach with produce farms, county extension offices, academic institutions, and national farmer unions to learn about the challenges and successes in vaccinating agricultural and migrant farm workers and to share CDC resources, including strategies employers can use to host workplace vaccination programs, ways to encourage employees to get vaccinated, and a toolkit available in Spanish to help employers educate their workers about COVID-19 vaccines. We partnered with labor unions and non-governmental organizations serving agricultural workers, including the United Farm Workers, MHP Salud, and the National Forum for Migrant and Community Health. And we engaged the industry leaders such as the American Farm Bureau Labor Issue Advisory Committee. In partnership with the Food and Drug Administration and the Department of Agriculture, the Vaccine Task Force assessed and improved data sources for the number and locations of migrant agricultural farm workers to support jurisdictional planning and estimation of allocation needs. When we saw that rates of COVID-19 were high and vaccination rates were low for racial and ethnic minority groups, we searched out partners who were trusted in those communities. Through our Partnering for Vaccine Equity program, we engaged with 22 national medical and professional associations and hundreds of community-based organizations to improve both COVID-19 and flu vaccination coverage among racial and ethnic groups experiencing health disparities. The partners included community organizations such as the Asian and Pacific Islander American Health Forum, the National Alliance for Hispanic Health, the National Minority Quality Forum, the National Urban League, Tribal Epidemiology Centers, the National Council of Negro Women, Unidos US, and the Conference of National Black Churches, and professional organizations such as the National Medical Association, the National Hispanic Medical Association, the Association of American Indian Physicians, and the National Council on Urban Indian Health. Other partners in this effort included some of our core public health partners like ASTO and NACCHO, as well as academic partners such as Michigan State University, the University of Florida, and the Public Health Institute. We also partnered with the Association of Immunization Managers, the National Association of Community Health Centers, and the National Network of Public Health Institutes. I could list many more partners for just this one program, but you can see that this has been a partnership across academia, local, state, tribal, and territorial health departments, professional organizations, and community-based organizations to work toward our goal of vaccine equity. Let me finish with an example of a partnership that exemplifies the power of long-standing relationships. Dr. Karen Remley is director of our National Center on Birth Defects and Developmental Disabilities and has served as Deputy Incident Manager for the Vaccine Task Force in the COVID-19 response. She and the Division of Blood Disorders have been working on partnerships with medical societies, recognizing the strength of those partnerships to make sure our guidance and their clinical recommendations align and are complementary and seamless. And she reminds us, to the patient and to the family, we are all one health and healthcare team. When information about thrombosis with thrombocytopenia syndrome, or TTS, emerged after the COVID-19 Johnson & Johnson vaccine was becoming more widely available, we were able to leverage a long-standing partnership with the American Society of Hematology, ASH, at a crucial moment. CDC and the National Center on Birth Defects and Developmental Disabilities collaborated with ASH and the hematology community to assess the safety of the vaccine and to provide updated national guidance on its administration. Within hours of reaching out to ASH, we had world experts on the phone advising and working alongside CDC and our ACIP colleagues. We relied on ASH's technical expertise to conduct analyses examining the risk of thrombosis involving cerebral venous sinuses and other sites in the body, along with thrombocytopenia. ASH and the hematology community proved instrumental in conducting extensive outreach to providers and clinicians, sharing the latest on potential risks for adverse events related to the Johnson & Johnson vaccine, and guidance on recognizing and managing TTS events. ASH's efforts, including presentations by hematology experts and the creation of clinical management resources, their availability to answer questions from CDC's Vaccine Adverse Event Reporting System personnel, and their participation on an Infectious Diseases Society of America clinical hotline contributed substantially to CDC's response. As Dr. Remley says, this decades-long partnership proved to be invaluable when we faced a public health emergency. Truly an example of the power of partnerships. Something to consider in your own work is how we can partner with professional societies to their benefit and for the benefit of public health. You have your own examples of how partnerships have supported, sustained, magnified, and improved your work, and you will hear many more during today's sessions. As I said earlier, we need many kinds of partnerships if we are to build a diverse and effective public health workforce, improve the quality of data and how we share information, and strengthen public health law, governance, and finance. Partnerships are powerful. I know that we can achieve more when we work together. Thank you.
Great. Well, thank you, Dr. Wilkie, and we certainly appreciate your time today and dedication to public health. So remember that you can participate in the discussion by posting relevant comments in the chat, and we'll periodically post a question to answer in the chat. We are posting the first question now, and I won't be announcing future questions, so please keep your eyes on the screen if you want to participate. Our team will also be posting live on social media during the sessions today, and if you want to share media on your own channels, use hashtag LCA Summit. Now, we will move to our first spotlight of the day, featuring Professor Dame Sally Davies, who was named UK government's special envoy on antimicrobial resistance. And she'll come to us today by video. Dame Sally will share a great example on how to build awareness and understanding of complex public health issues through the arts. Dame Sally?
Over the past 2 years, our world, communities and families have been rocked by global public health challenges of COVID-19. COVID-19 is not the last pandemic we're going to see, nor the only pandemic we're facing at the moment. Antimicrobial resistance, known as AMR, emerges when infections become difficult to treat and when antibiotics, those miracles of science, become less effective. Without antibiotics being effective and equitably accessible, modern medicine as we know it will fall away. Antibiotics have, after all, according to the World Health Organization, given us all an average of 20 extra years of life. On a global level, AMR imperils our ability to ensure that everyone, everywhere, is safe from global health threats, and AMR blockades our ability to meet the UN Sustainable Development Goals. On a local and more personal level, AMR means that my daughter's generation may not be able to have safe cesarean sections, for instance. It means that a friend with a cancer here in the US is 3 times more likely to die from a drug-resistant infection than other patients with infections that respond to treatment. I bet you will already know someone who suffered from AMR, as almost 3 million Americans contracted an antibiotic-resistant infection each year. AMR is an insidious and grippingly inequitable pandemic, but it doesn't make the headlines in the same way COVID has. Yet new data shows that nearly 1.3 million deaths were directly caused by AMR in 2019, and AMR was implicated in nearly 5 million deaths. Scientists' warnings have fallen on deaf ears. From Alexander Fleming's warning that misuse of penicillin would undermine its effectiveness back in 1945 and cause deaths, to the World Health Organization's sounding alarm that our global medicine cabinets are empty. The world is failing on AMR, so we have to come together. We have to be louder and bolder. The new data has given AMR visibility, but how much future generations will pay with their lives and economic insecurity depends absolutely on what we do now. We've got to fix the inequity in access to knowledge and education about AMR. We need to drive public awareness about what they can do to stay safe, and then to tip and push their congressional representatives into action. We have an out-of-the-box solution to the myriad menace of AMR, and I'm delighted that the UK government, with the support of the CDC Foundation, is bringing a new musical theatre production about AMR to stages in the US. The Mould That Changed the World. It uses creative storytelling and song with messages that educate and a language of drama that truly resonates. So we bring the power of the arts to enlist new audiences into a movement for change. The musical will begin its tour in Washington, D.C., where Congress will soon be voting on the new Pasteur Act. Alongside professional actors, we're going to recruit and audition local healthcare workers, microbiologists, science teachers and STEM students that will perform in the chorus giving these trusted members of local communities a platform and creating credible local champions for AMR. We'll encourage middle schools and science museums to hold their own junior versions of the musical using the free resources that have been developed. We're building student coalitions to activate university communities and participate in essay contests that will help us craft a message that will reach and resonate with the digital media savvy youth. Educating ourselves and each other is our most effective route out of the AMR pandemic. To keep our antibiotics working, we need to advocate and have equity at the heart of our actions. You know, everyone can be a leader on AMR, not just at the UN, but in hospital board committees promoting good antibiotics stewardship, patient advocacy groups petitioning for fair access to treatments, and in our own neighbourhoods driving behaviour change on hand washing. Partnerships across communities and between science and arts will build a mandate for policy action. More importantly, they will make a lasting impact on people's behaviour so we can rise above and turn this dreadful tide of AMR. We're all in this AMR boat together, and it's a horribly leaky one. To build forward from COVID-19 with equity at the heart of our health experiences, we've got to lead together, ratcheting up the pressure for policy change, bunging up those holes of leakage, and ricocheting the messages for behaviour change too. Thank you.
It's really great to hear how public health and the arts can partner, and it's very exciting to know that the musical will be replicated here in the United States to advocate with the public and to share messages about the importance of research, innovation, and stewardship. So before we hear from our first panel, we're going to take a pause and take a poll. It's going to be quick. So our first poll question is, what is the biggest challenge to establishing cross-sector partnerships? Choose only one option, but if you don't like any of the answers, you can check other and then put your answer into chat. I'll give you a minute to answer. The biggest challenge to establishing cross-sector partnerships. And I love seeing in the chat all the creative ideas to work with artists. It's fantastic. Okay, do we have our results? So the biggest challenge, lack of flexible funding, only having funding. Yep, so there you go, which is, squarely in what the Bipartisan Policy Center Public Health Forward was advocating for. But it looks like a distribution of challenges. Thank you all. So now what we will do is move to our next panel, and it's my pleasure to introduce this next panel, or the first panel, Co-Creating Success, Overcoming Challenges to Establish Multi-Sector Partnerships in Addressing Homelessness. Dr. Emily Bositas, Senior Advisor on Special Populations at CDC, will moderate our first panel. Thank you, Emily, for joining us, and I'm turning it over to you.
Thank you so much, Judy. I'm so glad that we have the opportunity to hear from this exceptional set of panelists today. Today we have Roseanne Haggerty from Community Solutions, an organization focused on ending homelessness, Dr. Bashara Koucher, who is from the Kaiser Permanente Foundation, Mike Gozi from the American Indian Community Development Corporation in Minnesota, and Robin Rose-Hamer from the Sacramento LGBTQ Community Center. So let's go to the next slide. Homelessness is a whole community problem, and therefore cross-sector partnerships are crucial to ending it and supporting the health of people who are experiencing it. So with that in mind, our objectives in this panel discussion are to describe the biggest challenges to forging effective cross-sector partnerships and how to overcome them, and use the model of addressing homelessness as an example of how multi-sector partnerships can make a difference. So we are going to go to our panelists. Hello, everyone. Thank you so much for joining us today. Let's start off with describing a cross-sector partnership that you've worked with. And also, if you could at the same time, talk about the conditions that have been necessary to make it strong and effective. Roseanne, why don't we start with you?
Thank you, Emily, and nice to be able to start with a story of great success. And while Community Solutions is a not-for-profit working nationally with now 98 counties and county regions to end homelessness and move toward a standard of ending, which is a population health standard of functional zero. One of the catalytic partnerships has been with Kaiser Permanente. We've been working with Kaiser Permanente since 2018 and now work collaboratively in 30 markets. And to the point about what has made this successful, it's, I think, the depth of this trusting partnership and just the aligned objectives. We are working in so many of these markets thanks to Kaiser Permanente's outreach to government agencies and officials and bridging those relationships and helping to bring this approach to ending homelessness into so many of their markets. They have invested in providing some of that flexible funding in communities like Bakersfield, California, in the last mile of reaching functional zero chronic homelessness. They've invested in a national housing fund through their Thriving Communities investment program that's allowing us to acquire properties to close last mile gaps in places like Baltimore and in Denver. And they're going deep with us as well as some other healthcare systems in a number of communities like Sacramento and Washington County, Oregon, to really probe what it's going to take for the healthcare system to join forces with communities, continuum of care, these COC entities, driving homelessness responses in communities across the country. So just to give you an illustration of the many layers of the relationship, I think that's that joined at the hip sense and willing to probe into different areas of our work has been so pivotal.
Thanks so much. Well, that's a great door opener for Bashar to jump in and add anything you want to say there.
Yeah, thank you, Emily, and thank you, Roseanne. It's great to be with you here on the panel. Just want to echo what Roseanne has said. I think when you think about it, as a health system for us, it was basic. We can't expect people to live healthy lives if they don't have a stable roof over their head. And that's really what drove us into that intersection between health and housing. Now, on one side, you have to make sure that our patients, our members, we're asking them about their housing situation. We're making sure they have stable housing. At the same time, we had to go upstream and we had to figure out how do we change the policy, the systems, the environments that are leading to homelessness. So we're not only working downstream, but we're really focusing upstream. And when you do that, you have to figure out the types of partners that you agree with philosophically, with the approach. And that's why we're so proud of the partnership with Community Solutions now in 30 of our communities, where we're leveraging data, we're leveraging community partnerships, on the ground conversations with elected officials, with continuum of care, bringing other health systems to the table as well. And we're starting to see reduction at population level when it comes to chronic and veteran homelessness in places like Honolulu, Washington, D.C., and other places. It's that type of deep partnership, rolling up our sleeves and trying to figure out how we can be successful in those communities. And Community Solutions is one integral part of our way we're approaching homelessness and housing in our communities. But we're also leveraging our Treasury Department and our investment portfolio. That's why we've launched a Thriving Communities Fund with $200 million that we're dedicating to investing in projects in our communities that would preserve or expand affordable housing. Roseanne mentioned 50 million of those $200 million are now on a bridge loan to Community Solution to help acquire and facilitate the acquiring of land and affordable housing units in a couple of markets like in Baltimore. But we're also working with the state of California, for example, on Project Homekey, where our initial investment dollars hopefully help catalyze a lot of the public investments into this effort that's now has housed about 8,000 people experiencing homelessness in California. So again, it's truly an all hands on deck. You roll up your sleeve, you find your partner, you go deep with your partner on understanding the issues and try to find solutions.
Thanks so much. So I think what I'm hearing here is that recognizing the intersections is critical and being willing to step into those spaces and make connections and those actions. I want to move on to our next question, and maybe this can be for Mike to start off with. So sometimes, even though we may have some very strong partnerships and positive relationships in our partnerships, sometimes there can be conflicting goals between organizations. So can you describe how you navigate those conflicts?
Good morning, everybody. You know, navigation of problems is really dealt with through communication. You know, AICDC has been dealing in homelessness since 1992, and so we have a long history of a lot of involvement at several levels. We try to work within all parameters, you know, because the outcome is basically for the person that is homeless, and our organizations have to realize that that is the mission, the goal. Well, we live in providing services for the lives and livelihoods of the folks that we deal with, and the homeless folks at this time, along with the pandemic and everything else, have really had a hard time. So we really look beyond that and really focus. Client-focused work is where we believe our best effort is placed, and so we continue to do that to the best of our ability.
Thanks, that's a great point. Just refocusing the emphasis on the people that you're serving. Thanks so much for that. Anybody else want to dive in on that question about navigating conflicting goals of organizations in cross-sector partnerships?
Well, Emily, I'll just add that, building on Mike's point, that kind of a process of overcoming conflicting goals or lanes of work does need facilitation. And we found that that's a critical part of the work that the Built for Zero initiative that we lead actually contributes. Getting in communities, the mayor, county executive's office, the COC, the housing authority, the VA, all around the same table, agreeing to the shared aim of reaching functional zero across the population, functional zero homelessness across the population, and agreeing to work as a nimble integrated team with shared measures of progress, and to construct a shared picture, a shared dynamic picture of this complex shifting problem by putting all of the data in one place, appropriately, you know, privacy protected. But that process of learning to work differently does require some facilitation, and that we've found that that's often a missing ingredient.
Thanks, that's a great point, Roseanne. So having a facilitated process, and something else that I heard you say was bringing out a shared mission so that those unique missions for each organization, you know, people can come together and focus on a single mission. That's really helpful. All right, so one of the things that we know is integral to effective partnerships is trust. So can we hear a little bit about building trust with your partners and with the community? I'll hand this over to Robin. And Robin, if you also want to just describe the types of partnerships you're working with first, that would be great.
Absolutely. Thank you so much for the invitation to participate. I'm super pleased to be here with some of these most amazing panelists. So thank you very much for the invitation. Our partnerships are both local and regional, and we're excited because several years ago, we decided, particularly in the youth homelessness space, that we would collaborate instead of compete. This has led to many larger collaborative long-term grants as opposed to 1 year and one-off opportunities. And ramping up and ramping down programs is one way that we have lost trust with community because they don't know when and where programs will be available and whether or not they'll be consistently effective. And so working with Sacramento County and 5 other providers in the region, we have been able to establish and maintain a prevention and intervention program for transitional age youth. And this program has really had the goal of helping youth to never spend one day out of doors. And that's exciting because of all of the adverse health effects that have been described about homelessness and people who are experiencing chronic homeless. So we're excited to be a part of this collaboration, and knowing that we are helping the downstream efforts of reducing chronic homelessness by helping youth to remediate their situation immediately. Sometimes that looks like a payment or even an intervention with a landlord about an issue, or it could be something as significant as domestic violence and helping that youth to relocate and identify places quickly. In the Sacramento region, the housing market is very tight, which means that typically it requires an intervention from a staff person to be able to remediate that instance of homelessness, as there aren't many available locations for people to transfer from one spot to another.
Thank you.
Maybe I'll add here also, Emily, I think the trust is such an important issue that we do have to deal with head on. And I think I'm actually going to start with the importance of addressing misinformation around some of the root causes and drivers for homelessness and the housing affordability crisis in our community. I think this past year or 2 years, we've learned so much about misinformation about vaccines. The reality is the misinformation about root causes of homelessness is equally challenging in our community. So that's why from our perspective at KP, we were on this effort or a journey to make sure that we're helping the public better understand root causes, better understand promising solutions, and really understand that housing and homelessness issues are a health issue. So as part of that strategy, for example, one effort we've worked on is releasing a documentary series on homelessness. It's called The Way Home. If folks who are watching today could check it out, it's really about a documentary that helps deepen the understanding, spark a dialogue, and really eliminate those root causes and promising solutions to the homelessness crisis. It started in California and now we're expanding across the country. So I would encourage people to check it out. Again, it's one example of how you leverage your voice to help build trust in addressing those important public issues.
Thanks so much for highlighting that. So I'm hearing both from Robin and from Bashara, we've got, to build trust in the communities that we're serving among people experiencing homelessness, and also the broader community so that we can do the work of ending homelessness. I wonder if Roseanne or Mike, do you have any examples of building trust with partners themselves?
Maybe one I can lift up is to go a little bit more deeply into this collaboration with health systems that involves Kaiser Permanente, but also Providence St. Joseph's, Common Spirit Health, Sutter, and UC Davis Health, and 4 systems working together in Sacramento. But I think we took the time in collaboration with the Institute for Healthcare Improvement to really try to pull together a shared theory of change for what a process would look like for these institutions that speak different languages, but are really so interdependent in terms of the ways in which vulnerable people experiencing homelessness are encountering both the homelessness system and the healthcare systems in these communities. And so I think the process of understanding the different languages, the different concerns, the different drivers of interest, different assets, different questions. We've been on this journey during COVID, and it's been extraordinary that these health systems have, with all of the pressures, made time to just stay with this process of testing, learning, figuring out how to share resources, information, processes. And so I'll just really speak to the relationship of time and trust, that it's we're, I think, going faster because we went slower at the beginning to understand that these were 2 cultures that needed to learn how to work together differently. And we think that as the result of this initiative, there'll be important groundwork gained that can benefit the whole healthcare sector, frankly, and how they can show up in their communities as a close and effective partner to those groups working on responding to homelessness.
I'd like to join in too. One of our greatest partnerships has been with the Healthcare for the Homeless through Hennepin County, and it's long established. And because we have AICDC has a lot of services provided to homeless people along with housing, and we were able to bring Healthcare for the Homeless into our housing opportunities to start having a relationship there with the people that were experiencing homelessness and now are in housing, but also we're able to bring the homeless folks into that same pool. And so we were able to establish a trusting relationship with Healthcare for the Homeless, but the Healthcare for the Homeless was able to start in really a larger partnership with or trust with the homeless people themselves. And that really, really helped us when it came to the pandemic, because we already had a lot of inroads into how we were going to get the homeless folks with vaccines. And it was based on trust and working knowledge.
You know, Mike's example is actually warming my heart. I've spent, about a decade working. I trained on a Healthcare for the Homeless program. I saw patients in Healthcare for the Homeless programs in Illinois. And that type of partnership is so critical. It's these folks who are in Healthcare for the Homeless programs who are on the streets, engaging with people, talking to people day in and day out, is leveraging that trusted messenger in our community is going to be really, really critical. The other example I'll add here is health systems across the country are actually also coming together to have these conversations. What role do they have to play in their communities when it comes to housing, when it comes to economic opportunity in our community, when it comes to diverse hiring, impact hiring? There's a big role health systems can play. And now we have about 60 plus healthcare systems from across the country coming together through the Healthcare Anchor Network to try to make sure that we have concrete actions that health systems across the country can do to help with housing issues, to help with economic opportunity issues, to help with food insecurity issues. And those types of practical, pragmatic solutions are really the types of things we need to continue to build on across the United States.
Well, so much. I want to draw us to one of the concepts that's come up a couple times, which is focus on the people that we're serving, people experiencing homelessness. So I want to direct this question to Robin. Can you talk a little bit about centering the voices of people experiencing homelessness in cross-sector collaborations?
Absolutely. It's my pleasure to be working with the Benioff Homelessness and Housing Initiative on a California statewide survey of homelessness as part of a lived experience advisory board. And the exciting part about this is that we get the opportunity to work with the researchers to help develop the questions and give them strategies about compassionately entering each community. And so members of the advisory board are from all of the counties across California that the survey will be administered. And some of the results have been pretty outstanding. It gives a much different picture than the point in time count administered yearly by HUD, and really gives a more deep and rich understanding of people who are experiencing homelessness and how that can be remediated through systems like the ones that we're describing today. And so as a dedicated advisory board member, it's my obligation to ensure that people in my community are protected and that information particular to them is raised up to researchers so that they have the information they need to be compassionate, empathetic, and also get the information to raise up the issues appropriately.
Thanks so much for that. I think that's a wonderful example and a replicable model for engaging people. So I appreciate it. So we just have a few minutes left, and I want to draw us back to a concept actually that Robin mentioned, which is that short-term projects sometimes are not a good way to build trust. Being there consistently, that's a good way to build trust in communities. So with that in mind, what are some strategies for developing sustainable cross-sector relationships and partnerships? And I will hand it to whoever wants to take the question first.
Well, I'll say, Emily, that when communities join Built for Zero, it really is to get to this end state of functional zero homelessness, meaning homelessness is measurably rare overall, quickly detected with public health quality, kind of a data awareness system, and also appropriately and rapidly resolved. And so the invitation is to work toward that end state, however long it takes. And so within that system building work, that is absolutely essential. Shorter term emergency initiatives have their place, but I think there really is something different in the way I think all of us are saying, like, our relationships with communities are about, being with you till the problem is solved. And that kind of vision and commitment to system building maybe has been missing in some of the ways that homeless services have been funded. Homelessness itself has been responded to sometimes more politically than systematically. And I'll just say, it's committing to a measurable shared end state, and whatever that journey is going to require is I think what we need now. And we're seeing more and more communities being willing to make that commitment. And I think, frankly, all of the complex challenges we're facing as a society require that kind of longer term thinking and structures for it.
I would agree.
Oh, go ahead, Mike.
Oh, go ahead. I would agree to that. I've seen some short-term opportunities go bad, because they were there and it was like hand washing. All right. Oh, good. We gave them something, and so we're done there. And that has not worked out in this history of homelessness. We're still addressing issues that have been years in the making, and by doing it in short spurts or short funding cycles really doesn't address the problem that we still have going on. And now it is more complicated than it was 10 years ago. And so we really have a lack of resources for the complexity of our clients these days due to opioids, trauma, and all the other things associated with homelessness.
Yeah, and maybe I'll add also to what Mike and Roseanne have mentioned. I completely agree about the importance of long-term sustainable commitment there. And maybe I'll take a slightly different angle when it comes to this fundamental shift that we're seeing right now in partnership between healthcare and homeless systems of care. And we're seeing Medicaid programs across the country starting to innovate there and try to think about how do we incorporate housing solutions and housing support as an integral part of how the Medicaid plans are designed and are funded. And we are committed to embed, as an organization, we are committed to embed evidence-based housing interventions that are sustainable and are sustainably funded through our state Medicaid programs. Now we have to continue to advance the field here because there's really need to continue to develop an evidence based on what works, what doesn't work, how do we have a rigorous evaluation, how we're looking at these innovative programs, how we're creating those strategic partnerships. But now we do have the opportunity to actually bring that into our environment. One example in California, for example, is the CalAIM efforts through for our Medi-Cal members in California. And as part of that multi-year plan to transform the California Medicaid program, the goal there is to improve the lives of millions and millions of Californians covered by Medi-Cal, including those with most complex needs, including those who are struggling with homelessness or housing insecurity. So we're having now more and more opportunity to think about how do we create sustainable interventions to support that intersection between housing and health, with California Medi-Cal program leading the way there, but also seeing it across the country in other Medicaid programs.
Emily, I know that we have just a few minutes, but I do want to just echo all of the comments of my panelists and speak to really the heart of the local nonprofit organizations. Many of the systems that we've discussed today are large and can bring huge amounts of resources into the system. And I just want us to all remember that many local community-based organizations are the folks who know community members the most. They have the most trust with them, and they have the most close proximity to being able to provide services, and realizing that everyone's not as sophisticated as some of the larger systems, but really they do have that tried and true methodology. And even though they haven't had the evidence-based practice opportunity to prove their outcomes, they have been able to be successful. And so just helping those organizations be able to achieve the level of evidence-based work and fund them appropriately so that they can help most people in need.
Thanks so much, Robin. I was hoping to give you the last word, and so thank you for taking it. With that, we're out of time, so I'm going to hand it back to Judy. Thank you to our panelists.
Thank you. Thanks so much, Emily, and to all our panelists, Roseanne, Bashara, Mike, and Robin. And now we're going to go to a quick poll. And our second poll question is where do most of the, where do we have the poll question up? There we go. Where do most of your current community engagement efforts fall on the spectrum of community collaboration? And again, you've got select one on here. And keep up the great discussion in the chat. I saw all kinds of great ideas and comments in the chat. Good questions as well. Yeah, a few more seconds here to answer the poll question number 2. And how did we come out with this? Where are most people, where's their current community efforts on the spectrum? We have the results? No, look at this. So 30% collaborate and ensure that community capacity to play a leading role. So you've got, that's really good. There's a small percentage that ignore altogether. So that's also interesting, and the others are in between. So again, thank you for the input on this, very helpful. And now it's my pleasure to introduce Lily Farang, co-director of Human Impact Partners. Lily will be moderating now our next panel, Meaningful Community Partnerships, Establishing Trust and Sharing Power. So Lily, over to you.
Hi, everybody. It is nice to see you. I'm hoping you can see the video. Please let me know on the tech side if you can't. It is lovely to be here with you all today. I'm joining you from Oakland, California, which is also known as unceded Ohlone land in Northern California. I wanted to thank so much the CDC Foundation, and in particular, Lauren Smith. Shout out Lauren for putting this amazing panel together that we'll be bringing you right now. I work for a nonprofit organization called Human Impact Partners. We're a national nonprofit, and we work, our awesome team of about 20 staff across the country work to transform the field of public health to center equity and build collective power with social justice movements. You can learn about us. I'll drop our website in the chat. And before we get started and introducing the panelists, I just wanted to really appreciate and kind of share the excitement that I really deeply feel about all the public health organizations and agencies who are making explicit commitments to advance racial and health equity. We've heard about those efforts in these summits. And I think the thing I want to reflect on is that while so many orgs are and institutions and agencies are growing more comfortable talking about achieving health and racial equity, they're a lot less clear and comfortable and skilled at talking about the importance of shifting power as a strategy to achieve equity. And so when I talk about power, who has it, who doesn't, how it's wielded, and for what purpose, it's one of the most obvious places where we see racial inequities manifesting. And so when we're bringing sectors together, like you heard in the prior panel, together, we have to really be thinking about how to shift power dynamics. For example, between public health institutions, academic institutions, clinical institutions, and community organizations who are more and more being brought into these partnerships. And that's what we're here to talk about today. And so core to starting this redistribution of power and thinking really differently about kind of power dynamics in cross-sector partnerships is having processes that are about building trust, deepening relationships, and acknowledging the harm that institutions have perpetuated in communities and having those institutions commit to repairing that harm. And so I think we talk at HIP a lot about creating containers that can hold more transformative relationships, which are really necessary for cross-sector partnerships to shift material conditions, to shift the social, economic, environmental, and political conditions that create health. So with that, I'm super excited to have a panel of partners who are experimenting and bringing these ideas to life. So we have Pastor George Nicholas of the Buffalo Center for Health Equity. We have Dr. Timothy Murphy of SUNY Buffalo Community Health Equity Research Institute, and we have Kelly Wofford of the Erie County Department of Health. And so our objectives for the panel are to identify successful approaches for building trust and to share examples of how to successfully share power and responsibility in these partnerships. So with that, hi everybody, now I can see your beautiful faces. It's nice to see you all again. So with that, we're just gonna start with an opening question and kind of go down the line with each of you just sharing for a couple minutes, like tell us, this group of over 1,000 people who are here to learn and share space with us, tell us your story of how you built a relationship among each other as people, as humans, and across your institutions. So how did you build trust, and kind of what it took to build trust across your different institutional locations and kind of the social and political location of those institutions. And we can just start, how about with Pastor George, since you're first on my screen.
Oh, good. Good morning and good afternoon, depending on where you are. And thank you so much, Sully, for your kind words. And thank you to the CDC Foundation for this opportunity. And in listening to the opening conversations in the last panel, it's really not that complicated. I think we make it complicated, but for us, we had a very serious issues around health disparities, especially race-based health disparities in Buffalo, New York, one of the poorest communities, one of the most segregated communities, and one of the communities that have some of the worst health outcomes in America. And so for me, as kind of the founder of the Buffalo Center for Health Equity and African American Health Equity Task Force, it was all about developing relationships, right? Who within our community is already doing this work? Who is already concerned about these disparities? And then looking at, what institutions within our community can have a positive impact upon the health disparities in our region. Who can really play a role, and not being so focused on their past historical inactivities, right? And writing people off because, well, universities never done anything in the past, or government's never done anything in the past, or corporations have never done anything in the past, and just like writing them off but coming and giving a clear vision about the current reality of our community, the impact, the suffering, the pain that's existing in their very communities, and the fact that we have a clear vision, a clear pathway on how we can address these issues. And we want to invite you to be in a relationship, in a conversation with us before we ask you for anything. We want to get to know you, and we want you to get to know us so that we can see on whether or not we have a shared vision of creating a new society, because you know the things that we have been doing in the past, while many of them have been noble and generous, the data shows they haven't been effective, right? And so just being very upfront and clear about that, and then finally being very clear about what our objective is. And we believe that race should not be a determining factor or a major factor on your health status, right? And so let's talk about how we can change that. I'm going to share, punt it to my colleagues so I can get going.
How about Timothy? You want to go next, and then Kelly can bring us home on this question.
Great. Yeah, thank you. Thank you for the opportunity to join this terrific program as well. I've learned so much already. I echo in many ways what Pastor George said, and I'll bring it from sort of an academic perspective. I'm in an academic life, and this partnership that we've created is just so important. I think the first thing in terms of how to change the dynamic for me was listening. I think those of us in academia sometimes don't like to listen that much. We talk too much. And it was really listening. I've read about health disparities and health equity, and I see it. I've seen it for decades in my clinical care activities and so forth that I've had, but I don't have that lived experience. And I think that really was very influential for me in our meetings in developing this partnership. So I think that's the listening part is really important. And the second thing I think is that consistency of the commitment. As Pastor George said, we have a clear vision about where we want to go. But we can't, as a university, I think too often we have an idea, we go to the community and say, here's our project, we help us out, and they help us out, and then we go back and then we don't do anything until we have the next project idea. And really what we need is the relationship building, the consistency of that commitment. And actually, Dr. Walensky said it in her opening remarks, is when you have pre-existing relationships and that consistency of commitment, and you're faced then with a crisis, that's when you can really do big things with a partnership like this. And in a way, that's one of the things that happened with us and our partnership during this pandemic as well. And I'll stop here.
Again, I just want to say thank you again for inviting us and having this conversation in this way. We had such a dynamic pre-conversation that to be able to articulate all of that in 30 minutes is going to be tough, but we'll do the best that we can. And so in my relationship with this particular movement, I've represented both county hospital and now county public health. And it is being able to, yes, listen, and being able to translate information, right? We need to be able to justify really the work that we're doing from this perspective. Why does a safety net hospital need to spend so much time working on upstream issues when the emergency room is filled, right? And so you have to be able to have conversations about the social determinants of health. You have to be able to translate those conversations oftentimes into dollars. You have to be able to translate that into length of stay. You have to be able to talk about, why people are coming to the emergency room because they need a meal and they're so sick that they can be admitted. They didn't come to be admitted. They came because they needed a meal, right? But blood pressure, diabetes, heart disease, kidney disease, so many health outcomes are so incredibly disparate in the communities of the folks that we reach, that you can be admitted to the hospital when you're hungry. Right. So being able to translate that to justify why we need to be at the table was, I think, imperative. And the need to be able to then bring those services, that understanding to the conversation when it comes to the task force gathering. So being that translator was necessary for me from this vantage point.
Thank you so much. I love hearing you tell this from your own unique perspectives. And I think one thing we chatted about in the prep call was sort of how you live in these communities too. And so like you're navigating between kind of different roles and how you're showing up in spaces, but not just like in a professional identity, but as like a whole human. And so I think to that point, I'm curious how the mutual appreciation and trust that you all developed really shifted the kinds of work you did with one another. So how did that basis of establishing a strong sense of trust and kind of co-ownership and mutual appreciation and admiration for one another actually shift what you did? Does someone want to go first, or you want me to call on you?
Why don't you start, Kelly, and then.
Yeah.
It started with truth telling, right? And the need to have open and honest conversations and to understand that this work is going to hurt, right? You are going to have to confront some things in your life, no matter where you sit. You're going to have to undo some learning and undo some thought processes in order to be able to address health equity in the way that it needs to be addressed. You know, we've always helped the least of these, but the helping has been downstream, and we need to be able to, you know, push that upstream. And in order to do that, you have to have tough conversations about language. We took time to learn about each other's upbringing. We took time to be able to, you know, I remember one conversation, someone used a term that was derogatory that ordinarily you would just keep the conversation going. It wasn't overtly so, but it was something that we, you know, something that you use often. And not being in this environment, that comment would have just been ignored and you would have kept working. But we had to stop and take time and unpack that and say, we can't use that kind of language because, like, this is what that means. And this is what it means to Black folks. This is what it means to women, right? And to know that it's okay to make that mistake, right? So we had to create an environment where it's okay to make a mistake, knowing that you'll be corrected in, I'll say, love and grace, because that's really the environment that Pastor George cultivated for us to be able to do.
You know, one of the things that I think helps us is just, as Kelly mentioned, that we were very clear that we're not trying to start another service delivery system, right? We support the people that are doing, you know, charitable work and what have you. And think it's a good thing, but we are very clear that we are focused on systems change. We're very clear that you know, you can't just keep building program after program after program. At some point, you got to figure out why so many people are suffering, why so many people have these poor health outcomes, and it's a systems problem, right? It's a system that we're all part of, but we play different roles in. And we have different levels of influence and power within those systems. And being very clear, when we started talking with the university and the insurers and others, and being very, very clear that they have at times been complicit in creating some of these poor health outcomes by their own current practices, but we want to invite them to look at a new and different way in which they can operate in order to operate in a more equitable way so that they can help produce or help be a positive influencer on these outcomes. And then one other thing real quickly for Dr. Murphy comes in is we were from day one very clear about the issue of race, racism, anti-Blackness, white supremacy, whatever term we want to use. We are very clear about those issues and how they drive some of these poor outcomes in the Black community. And so we don't have a debate whether or not, you know, racism is a factor, or that's we're very clear about that. And we're very clear that we have to speak to those things in a very clear, unambiguous way, so that we can really begin to do the work. We got rid of all the eggshell type conversations really early, and we just had to keep it real, because people are suffering while we're trying to figure out, you know, how we could talk to each other. People are dying, right? And so at some point you got to say, we're going to work together. We got to understand these realities. We're going to build these relationships, but we understand there's a sense of urgency behind our work.
Thank you so much. Yeah, Dr. Murphy.
Yeah, I mean, the relationship between our groups of the university and the community really has changed that dynamic in many ways. I think that for too long, and certainly in our university, I think it's the way it's been, that community engagement and partnership with the community is considered a social responsibility, and that we're having a paradigm shift, quite frankly. And you know, university views the community as an asset. So as an example, the community leaders and community members are teaching a course in the School of Medicine called Health in the Neighborhood, and teaching our future healthcare providers to understand the social determinants of health. So when they take care of patients and they see patients, they can see them in the context that their health problems exist, which has not happened so much before. It'll help the way our future healthcare providers provide care. It also, this whole dynamic increases the impact of our research discoveries. You know, this is what we want to do, is, you know, do the important research, but then actually have this research make a difference in communities, if we're really going to have the research make a difference in the health. So it's really, I think this relationship has changed, and it's reaching the highest levels of university leadership as well, that I can talk about when we get to our next questions a little bit. But it's a paradigm shift that's happening, I think, in terms of this mutual appreciation and trust that we're having between the university and the community.
I love this. My cup is being filled just listening to you all. It's, you know, 9:20 here in Pacific time. So this is really good for my energy for the rest of the day. Thank you for bringing yourselves. So Pastor George, tell us just in a few minutes, if you don't mind, kind of how you created spaces in your coalition settings and, you know, in the network settings where you were bringing all these groups together that really disrupted power dynamics. How did you sort of shift the power dynamics that exist in the world, that show up in the room, even if you're trying, you know, all that?
Right. Yeah, thanks for that, Lily. Well, a lot of it is leadership, right? You know, it's about creating spaces that dismantle some of these traditional understandings. For example, just because you have money, or you represent a corporation, or you represent an institution or a funder, doesn't necessarily mean that you are more important at this table than the block club leader, right? And so we don't genuflect to people based on their titles, based on the institutions that you represent. Around our table, it's a group of people who are really concerned about health equity and are willing to work together in. And the word collaboration is good, but I like to use the word cooperation, you know, so because we're both operating for a process of building something that is going to make our community better. And so around that table, everyone is literally an equal. Now, we also hold people accountable for the resources or the things that you can bring to the solution. So while a block club leader and a head of a foundation can be around the same table, the expectation of contribution to the cause is not the same, right? And so if you have access to resources and ways in which we can influence this problem, we have an expectation that not only do you come and be present, but you are willing to go into the places where you serve and work and bring those resources into this space, you know, not to wield power, but because you're really committed to seeing the solution.
I love that. I love that. That is such a good setup for Dr. Murphy and Kelly. So when you hear that, sort of how did that look and feel? How did that shift the energy that you're showing up with representing your institutional system in that space? Like, how did you sort of model that accountability based on the resources that your institutions came with? And maybe we could start with Dr. Murphy first and then Kelly. Is that cool? Thank you.
It's really changing how the university views the community. I think for a long time, our university and many universities, health equity and health disparities and that sort of work depended on an individual faculty member or a student or a project or a specific program to actually get legs. And then when that faculty member left or retired or stopped working in that area, it stopped. And so what's happened now is that we have institutional buy-in. In fact, it's these meetings and this partnership that led to the launch of the Community Health Equity Research Institute in 2019. In fact, Pastor George and a couple of other of us and a state senator met with the president and the provost of the university and talked about this. That was in 2018, 2019. And the president and the university launched and supported this institute that is specifically the goal is to focus on health equity in the community. And this is important for the sustainability of these efforts. And the other thing that it's done is it's given us buy-in from the faculty. If we're really going to change health disparities and achieve health equity, we got to get way beyond the health sciences. You know, we need the School of Law for the inequities in the criminal justice system. We need the School of Education for educational opportunity. We need the School of Management for poverty and dealing and so forth. And so a lot of our faculty don't really recognize how their work interfaces with health equity. And so having a university institute, having the buy-in of university leadership gives that work more credibility, and it allows us to attract more people into that area. And that's how we're going to make a difference.
And, you know, it looks like when in action, it honestly looks like the Office of Health Equity, you know, here at Erie County, right? The office has only been open 2 months, right? There was a law that was passed and this office was created, but it started at a community meeting at a church where Pastor George called community folks and hospital folks together to hear about health disparities in the Black community. That grew into now we have a government office that is founded and based on a local law that has been established to address health equity for all marginalized people in Erie County. That's huge. That's huge. And so we have to, in addition to having an institute at the University of Buffalo, an institute has never been created in 8 or 9 months, right? But being able to be the drivers of the conversation and presenting facts and not really feelings, people are dying, that is a fact, right? Being a Black woman in Buffalo, where I grew up, where I live, I will live 8 to 12 years less than my white counterpart who has a similar background as me. Those are the facts, right? And so we have to get past feelings. We have to get past, you know, I don't think that's going to be a nice thing to do. It's not about being nice, it's about saving lives. And so when we consider the impact of the work we're doing, we can see the growth. One of the things that let me know that this group really had it, that this was it, was at our first conference. And we, you know, had sign-in tables and, you know, a lot of what's considered menial work. right? And we were already all on a first name basis. Tim was Tim. Tim's got 20 letters after his name, right? He's Dr. Murphy. But when we're together, he's Tim. And so are the other doctors. So are the other folks with letters after their name. But at the conference, at the sign-in table, was a dean of one of the schools, not signing in, but leading the sign-in table. And so you begin to see the shift. Students are coming in and they're like, oh, Dr. So-and-so, you sign in here? They have not seen that before. There has always been this, exalting nature when it comes to academia, right? Oh, the great Dr. So-and-so, right? When you have a table of folks that are equal, it comes across in things like that. And you've made a change and you've made a difference when people are shocked at something that you see as completely normal.
Just so you know, you're all getting so much love in the chat. I'm sure you're not tracking it. I can't help, but there's so much, there's like clapping, there's heart emojis, there's like the word love written many times. So you should, I hope you can take that in. So we just have a couple minutes left. And I think what I would just love to do is end. Let's go with Timothy, then Kelly, and then we can end on Pastor George. Just a minute each on just like what are parting words for the folks who are listening in today around kind of just either what they can do to get started thinking about these things differently, or why kind of shifting power feels important. I mean, you've been talking about all these things. So really just a parting word or two for the participants. And we can start with Timothy, Dr. Murphy.
So I think, Tim, yeah. So I think that if we're really gonna move the needle, as we say, we need to engage many sectors in the community, many disciplines in the university. As I mentioned briefly there, we think of health equity as, yes, we look at health outcomes, but those health outcomes are determined by mostly 85% by things other than the health sciences and other than healthcare. And so we need to be all in on this together in order to actually really make a difference.
It's going to hurt and it's going to take time, period. We have to be able to take our feelings and our egos and put them to the side and realize that the work that we're doing is truly saving lives. Again, case in point with the Office of Health Equity. We focused on a particular group, and many folks were upset that this group was working together only to address the needs of African Americans and Black folks in Buffalo. There were many issues and conversations because of that. But now look at where we are. All marginalized people in Erie County are in a place where they have an office working to serve them. So once we realize that helping one helps all, we'll be in a much better place.
It's about relationships. I keep going back to it. And it's about having, not transactional relationships, but transformative relationships. And I would challenge those of you who are doing coalition work around the country, it looks like around the world, I saw some people from Portugal and other, have some conversations with the people from different sectors that it's not about the money or not about the project. There were times when these were new relationships we were developing. I mean, I never knew Dr. Murphy before this work, but now I consider him a friend because we can have conversations about our lives, about our kids, about whatever. And that is so important. And I think one of the biggest mistakes that we make is we enter into these conversations cross ethnicity, cross sector, cross life experiences. And then then you start working on your narrative for your grant you're going to fill out. And you don't even know the people in the room. You don't know anything about them. You don't know anything about their passion around this issue, or are they just at this table because the CDC sent out something looking for some, and you're looking for some money, right? And so I want the people to really know that we met for years and we never talked about money. We always talked about what are we trying to accomplish here? What do we want to see happen? And then once we were clear about that, then the money and the organizations and the things that have been able to be developed, our center, the Buffalo Center for Health Equity, just got, we didn't get a chance to talk about private partnerships. Highmark Health Insurance just granted us $5 million, right? And I never asked them for $5 million, but it was because of the relationship that we had developed. They saw the work that we're doing, they saw what they had a vision, and they said, we want to invest in this because it's dealing with root causes. That comes from relationships. And so take that time. I know we're all very busy, but I'm telling you, it's worth it because you'll be able to be far more effective. So when it's time to put together those grants and all those other things, those applications, we're able to do that thing pretty easily, quite frankly, and without this mistrust, like, hey, what are you getting out of this? And what am I getting out? We've already had those conversations. So now we're just ready to do the work. Thank you so much for your time.
Oh, thank you. So I do something, I lead a lot of trainings. And one of the things I do, especially when I can't see all the people, is I do a round of applause. Cause I'm like, y'all just gave us, you know, a half an hour of your words, your kindness, your love. And I just feel like you can't hear all of the people who are applauding you, but I'm giving you a round of applause. Thank you so very much for making time. We appreciate you. I'm not sure who I'm passing it back to, so someone should just interrupt me to take it back.
I've got it.
Thank you so much.
So thank you so much, Lily, Pastor George, Timothy, and Kelly. Yeah, there was a lot of love for the panel, I have to tell you. So next, we had planned to move to another spotlight, if you're following your agenda, with Clinton Alexander of the White Earth Nation, but he had an unexpected emergency, and so we'll miss having him, and instead we will move into our next quick poll question. And this time, this is on community partners. So the question for y'all to answer, the term community partners can mean different things to different people. With which of the following groups do you partner the most? And in this case, it's one answer, but you can enter other. If you have something that's not on the list, put it into your chat. We'll give you a little bit of time here to answer this question.
Judy, we're having some technical difficulty with the poll. It's not launching, unfortunately. We're going to give it another shot.
Okay, we'll give it one more try, and if not, we'll just keep moving then.
Yeah, people are answering in the chat, which is great.
Perfect. Okay. All righty. So I won't be able to do a tally on the everything coming in the chat, but keep putting your answers into chat on this poll question, and I think we'll go ahead and move to our next panel. And this next panel will be innovative strategies to mobilize and sustain high impact partnerships. So I'd like to welcome our moderator, Todd Stoltz of Healthy Davis Together. Todd, we're excited to hear about your work.
Judy, thank you very much. And thanks to the CDC Foundation for putting on this webinar, really important topic, and giving us the chance to talk about Healthy Davis Together. But before I do that, though, I just want to acknowledge the two panels before this were really extremely good. And thank you all for those topics. As an employee at UC Davis Health, I am aware of the work we are doing with our community partners around the homelessness issue. I'm not directly involved in it, but that is such a difficult topic and clearly a topic that requires multi-sectoral partnerships to address. So a really timely panel and important panel to have. And so thank you all for the work that you're doing. Great work. So we're here to talk about Healthy Davis Together. And this is a COVID-related project that we started back in July of 2020, when a group of doctors, epidemiologists, and a few others got together to sort of look at and think about the unique circumstance that UC Davis and the city of Davis were in with respect to shutdowns and the challenges that COVID was causing. There was, I think it was a Forbes magazine article that was published around that time that lists actually the city of Davis as one of the top 10 cities most vulnerable to shutdowns of universities, because the city and the university are so tightly integrated, which has a lot of advantages, right? But in times of COVID, if the university completely shuts down, really would have a dramatic economic impact on the city of Davis. So we started to think about, what would happen to the city if the university really did shut down, and what could we be doing to help support that? And the campus, fortunately, was developing quite a lot of COVID mitigation efforts that were very intriguing, right? The most interesting, of course, was a saliva-based PCR test for COVID. And that test was free to students, staff, and faculty on campus that needed to access campus facilities. It was a fast turnaround time and really drove the use of asymptomatic screening, right? If you remember back in early to mid to late 2020, even the COVID tests were a nasopharyngeal swab, right? So this was lovingly referred to as a brain biopsy, and getting people to come back frequently to get a brain biopsy for a COVID test was a non-starter, right? So the UC Davis lab that developed this saliva-based test was really a game changer. And we started to wonder, what would happen if we offered that test not only to the UC Davis community, but to the broader Davis community at large, right? Davis is a city of about 70,000 people. The university is 30 to 35,000 people. So it wasn't unimaginable. It wasn't unsurmountable to consider how we would offer those services to the entire Davis community, as opposed to some of our other universities, which are in much, much larger cities of millions of people. A little more difficult for them to think about how they would expand those services. UC Davis was also offering quarantine and isolation services, right? They had dorms set aside for students that tested positive or had roommates that tested positive, and they needed to go quarantine or isolate. They could move into a dorm that was specifically set aside for that. So we wondered what happens if we did that and worked with apartment complexes in town to offer those same services to residents of Davis that weren't associated with the university but needed access to those services. There was a lot of wastewater monitoring that was going on the Davis campus. They were monitoring dorms and a few research buildings that were doing that contained research activities that couldn't be stopped during the pandemic. So they were doing wastewater monitoring. UC Davis also has its own wastewater treatment plant, so they were monitoring at the treatment plant level as well. We wondered, okay, let's expand that to the city of Davis there. And then they had a robust communications campaign that they were starting to put together. They developed a workforce of public health ambassadors that were mostly undergraduate, pre-med students or graduate students in public health sciences that were interested and engaged in being involved and knowledgeable about the subject, but needed some organization around what they might do. So they were developing a workforce of public health ambassadors that we wondered, okay, could we deploy that workforce across the city as well? So we started to put that together and think about what it might look like, and we're fortunate to be able to deploy a lot of those services, across the whole city of Davis, and even expand over time into Yolo County more broadly. Yolo County is the county that Davis is in. And like I said, Davis is about 70,000 people. Yolo County is about 220,000 people. And since then, we've done 1.6 million COVID tests. A little bit more than 800,000 of those have been done on campus for students, staff, and faculty that are mandated to test in order to be able to access campus services. Slightly less than 800,000 of those tests have been done out in the broader community. who don't have a mandate to test, but we wanted to make testing freely available, easily accessible in the community, fast for them to do and get a good turnaround time. 99% of our results have been turned around in less than 24 hours to people. So they could get a test, get a timely result, and then take action appropriately with those results, right? We've monitored tens of thousands of wastewater samples, not only from the wastewater treatment plants, but we also set up sub-sewer shed monitoring within the city of Davis so that we could see if a neighborhood was in particular starting to show an increase in positivity, and then have our communications team go in to help that particular neighborhood with testing and mitigation efforts around, that neighborhood should be aware of the rise in that group. And then I mentioned the robust workforce of Aggie Public Health ambassadors that we've developed. This was several hundred students that are still active in the community, evangelizing good public health measures and knowledge around what's going on with the pandemic. In addition to that, we've been able to launch a pretty significant advertising campaign and social media effort, so that if you're in Davis, you're pretty much going to hear about Healthy Davis Together and know what we're talking about. So I'm really fortunate today to have 4 partners that were absolutely critical to launching and implementing this program, because we quickly realized there's no way we were pulling this off without a lot of effective partnerships. And we almost right away went to Mike Webb, who is the city manager for the city of Davis, and started talking to him about this project and what we were thinking. And Mike was terrific at the start and has been terrific a partner throughout. Very, very open-minded, very clear communication from him about where his restrictions are, what his limitations are, what he can and can't do, what his team can and can't do, and what they could do and what was important, right? We also reached out to Dr. Melissa Marshall, who's the CEO of Communicare Health Clinic, which is a federally qualified health center, not only in Davis, but also operates broadly across Yolo County. And we really wanted to make sure in our project that we weren't leaving out any underserved populations, any populations that exist on the margins. We wanted to make sure we were catching them as best we could in these programs, especially when it came to the quarantine and isolation support and any other financial support that we were offering to people that would leave their jobs in order to quarantine and isolate. We wanted to be able to be sure to compensate them for that time off. So Melissa has been a terrific, terrific partner in helping us reach those populations with a credible voice, right? She has an established relationship with those groups. They know her, she knows them. Nobody knows us, right? So it was easy for us to work through her to reach out to those groups. Garth Lewis has been, the superintendent for the Yolo County Office of Education. We obviously wanted to work with K through 12 schools to help them with reopening, right? So obviously testing, but other air filters that we put in classrooms and other COVID safety measures, mask wearing, airflow monitoring in the schools. What else could we be doing to help schools open? And Garth has been a tremendous partner for us to help us understand what the school districts could and couldn't do, where their limitations were, and help us understand the different school districts around the county and sort of the different perspectives and constituencies that they had. And then lastly, Esmeralda Garza from Yolo County Office of Public Health has been an enormously helpful partner for us in being able to reach out to some of the farm worker communities that Dr. Walensky talked about at the start of this. Really important COVID mitigation efforts around, because we're right in the middle of the Central Valley of California, right? So reaching out to the farm worker communities and being able to effectively engage with them, very important for us to do to maintain the health of the community. And without Esmeralda specifically and the Office of Public Health generally, never would have been able to accomplish that. Okay, so enough of me talking. Let's see if I can get the panelists to talk here. There's some questions that we put together. The first one is, and I'd like to get each of them to talk a little bit about this, to talk about an example of a partner challenge that we've had, at the start, and how it was addressed. So Melissa, if you don't mind, could I start with you on this?
Thanks, Todd. It was just a wonderful collaboration. And I think, when we started, there were certainly challenges because our colleagues didn't have the same experience dealing with the population that we do. And just as an example, when we first started giving vaccines, we had to make 10 outreach attempts for every vaccine that we gave. And I think, UC Davis was probably more accustomed to people coming to them and not having to do that level of outreach. And so we, when we first started working together on vaccines specifically, we were giving them not only vaccine, but our patient lists. And we needed support in terms of workforce to get vaccine out there as quickly and effectively as possible. And they were just tremendous on that front to offer the workforce. But it was a new thing for them to have to make 10 phone calls, for every vaccine that was delivered. And of course, things changed as our environment changed. But that was certainly a challenge in the beginning. And, from our perspective, the health equity issues in addressing the population that we care for was incredible. We care for 1 in 9 Yolo County residents. And, most of them are either on Medi-Cal or they're the remaining uninsured. Many are migrant farm workers. And without reaching out to them, those that were disproportionately impacted, we were going to lose this fight. So this partnership was tremendous in really overcoming the fragmentation that we all experienced during COVID-19.
Thank you, Dr. Marshall. Esmeralda, from your perspective, how did this work with your group?
I think I'd have to echo the same sentiment as Melissa, is that HDT was very accustomed to have the community come to them, and they were successful in the university and the Davis community fairly quickly, but that did not occur with our marginalized communities like our farm worker community. So in Yolo County, we have 3 migrant centers. Most of the residents who come from Mexico, and so they're here between April and October. And so one of the things that HDT did was they were able to provide regular surveillance testings for one of our migrant centers. But they were quite shocked to show up and find that there was no uptake in the services. So what the challenge was, and what was really lacking, was that trust and that cultural humility. So what we did to mitigate that was, consistency. HDT showed up week after week, but we also did a welcome event where we brought in familiar faces to the residents that they had seen in prior years. We offered them a welcoming basket with PPE and household cleaning supplies. And we introduced them to the HDT team and said, this is who they are. This is what they're going to offer. They're going to be here week after week. Come show up. We're here to serve you. And so in the beginning, HDT staff were very shy, very nervous to approach the farm workers, and the farm workers did not trust HDT. They were not coming up to the tables. So some of the other things that we did is I took HDT staff with me and I said, we're going to go knock on doors. And so we started knocking on doors, and I started initiating conversations with the farm workers whom I was already familiar with. And so I was setting up that example for the HDT staff, and then next door I'd say, all right, your turn, let's go for it. One of the other things that HDT did was they provided dinner. So people would come test, they provided dinner, not just as an incentive, but really as a resource. A lot of our farm workers, they come home tired, exhausted from working a very long day. So testing after they come home from work and getting that plate of dinner to take home with them was a tremendous resource for them. So a few weeks into the project, and it's something that I'm going to remember forever. I'm standing there assisting an HDT staff serve dinner to a resident, and the HDT staff is trying so hard to speak Spanish, and not just speak it, but really trying to offer the service in a very friendly, very culturally just humble way. And I could see that she was trying so hard. And so she starts talking to her and not just offer the food, but spark a conversation. And to our surprise, the farm worker started speaking English. And she struggled, but she did it. And then she said to me in Spanish, if she's going to try really hard to speak to me in Spanish, then I'm going to try and do whatever I can to speak to her in English to make her feel comfortable. And that to me was just cultural humility at its core, being able to make yourself vulnerable. And even though you're the one offering services, realize that you are a student in that situation. This is a population that you're not accustomed to serving. And so you really need to take that extra step and learn about the people that you are trying to serve to be able to offer those services in a culturally humble way to be successful and have those relationships. And as the panel prior to us mentioned, trust is key.
Esmeralda, thanks very much. And obviously, Dr. Marshall's support and your support in helping our program and our staff understand those challenges was critical. Garth, anything you'd like to add to this from especially the even pre-K, but K through 12 perspective?
Thank you, Todd, and good morning to everyone. From my perspective, I would say that the headline here related to the partnership between schools and HDT would be that timing matters, as do communication and execution. And so for my part, I chose to really focus on the challenge related to timing. The timing involved in the project transitioning from serving a single school district, the school district in Davis proper, to scaling across the county. And from the perspective of school leaders, that particular challenge was extremely problematic in the beginning. And in large part because the timing of this scaling effort occurred after alternative testing resources had been procured and initiated by the other 4 school districts and the County Office of Education through the state's lab. And so in terms of context, regarding the timing for this scaling effort, the request to scale HDT across the county was approved in April of 2021, whereas school districts began planning and securing testing protocols and systems really just before winter break during the previous year. And so for a couple of months, 3 months, planning was taking place, and in fact, we had begun the testing process. And as many as you know, in the period of COVID, 2 months really felt like a lifetime. And for us in the school community, this really mattered because we were in the process of planning our reopening for schools, and schools in California were required to demonstrate readiness through standing up testing sites in order for us to reopen our schools. So superintendents and school boards, they had to work quickly to plan and then execute on their goals in order to offer in-person instruction, which we knew our students desperately needed, our school personnel desperately wanted, as did our families. And so by the time we were able to scale the services with HDT, we already had MOUs in place, training of students and families and staff had taken place, and the testing protocols were a regular occurrence in our schools. And so the benefit of HDT was a challenge for school districts to really understand on the front end. And the strength of availability and the communication on the part of our HDT partners I think really carried the day in that transition, so that the value proposition that was in front of school leaders really was the ability for us to have a more coherent system of mitigation strategy across the county. We were also sold on the saliva testing, as Todd pointed out at the very beginning of in his comments. That was a huge selling point. And the fact that we were able to, many of our school leaders were able to visit our colleagues in the Davis School District, observe the success they were having, actually practice practice delivering the tests. The ease of that particular protocol really became a selling point for the transition. And so the communication, the regular communication that was experienced on the part of our school leaders with knowledgeable HDT staff, as well as the training and technical support they were able to provide, those were selling points. And then the execution with regard to the specific testing protocol and the ability for us to receive our test results within 24 to 36 hours, generally within 24 hours, really allowed us to then keep the schools moving and as many students as possible in the classroom and teachers teaching. And so our goal was not simply to open schools, but to keep schools open. And so the resources and the execution on the part of HDT really helped us to facilitate a position of strength in that regard. And so for us, again, the communication and execution were key to getting over that hump with regard to the timing. I appreciate the opportunity to share.
Thank you, Garth, very much. Mike, any quick points you'd like to make on this topic?
I think some of the challenges or that we faced, there were many throughout the Healthy Davis Together program. But the key point is that we had a team, a multidisciplinary team, as you can see here, from university to county to health officials to the city, to our community-based organizations, where everyone was a willing partner participant, and everyone came to the table really to make things work and to say, how can we make this happen? How can we make this work? How do we adapt to make things work? A very brief example is we had a component of Healthy Davis Together called our Business Partners Program. So not forgetting that our economy is crucial, at all times, and there's no, during a pandemic is no exception. If to evaluate it strictly from a public health and epidemiological standpoint during COVID, when COVID first started, the advice was, everyone should just stay in their homes and not go out. Don't go to businesses. That's not the healthiest approach of things to do, right? It creates exposure, it creates risk. And, so we had some real good discussions about, well, okay, that works from a pure public health, policy standpoint, but what community would we have left after COVID if we did that? If everyone literally holed up in their homes, never came out, never went to businesses, never patronized our businesses, what economy, what jobs would be left, what community would be left? And so we created the Business Partners Program in recognition of the fact that the economy was sort of crucial too. And so what we did is took the approach of saying, rather than not utilize our businesses and go to our businesses and help them keep going, but let's provide support for those businesses so that they can provide their services as safely as possible to our community members. And so we provided, through Healthy Davis Together, we provided grants to businesses to put personal protective equipment in place, to do training for their staff, to make sure that they were invoking the safest possible business practices that we could envision and help support.
Mike, thanks very much. So in the interest of time, I'm going to jump around here just a little bit, but I'd like to ask if Esmeralda, you could give a kind of a quick response to our second question, which was sort of one piece of advice you'd share with other communities based on your experience, right? And what are the most important ingredients that you feel would other groups could benefit from?
I think I muted. You know what, I think what was really special about the collaboratives that emerged from this pandemic is that there was a lot of selflessness. A lot of times when you're working with other collaborators and projects, there's always a power struggle. There's a lot of friction and tension. And so everybody wants to shine. But throughout this pandemic, I think I saw a lot of selflessness, just finding common ground, focusing on the goal, sharing resources to able to maximize impact.
It's a really good point. And one of the things we've seen in the COVID pandemic, right, is that one of the advantages of it was it sort of aligned everybody's goals fairly quickly, right? We all wanted to do what we could. And a lot of people at the university really jumped in to help with this common goal that we all had. So I think that made our jobs around aligning interests a little bit easier than perhaps in some of the other circumstances. Mike and Dr. Marshall, you're both leaders of very different types of organizations. Any lessons that you might want to share from a leadership perspective around, sort of what brought this together for you?
Sure, I can jump in on that real quick, Todd. From a leadership standpoint, from coming from a city manager, which I'm probably in fairly small company with this conference, but from a city manager perspective, I encouraged local leaders, local government leaders, cities, counties, and so forth, to always keep in mind that we exist as government agencies for the purposes of public health, safety, and welfare. At the end of the day, that's what it's all about. That's why we exist as cities. And all the things that we do as organizations sort of fall from that. And so that's crucial, I think. And then the other thing I would add briefly is being always in leadership positions, always being open to trying new things, which sometimes involves taking some risks. And risk of failure sometimes, but we don't achieve great things if we don't take some risks.
Dr. Marshall, anything you want to add to that?
Sure. I just think that listening and cultivating shared values was really key in terms of the leadership. And while it's easy to say that we had shared values, we really had to kind of keep those as our North Star while we prioritized what activities we focused on. And I think that was really key. Thank you.
So we're running short on time. Don't want to take anybody over time here because I know everybody's time is valuable, but could you talk about any of the perhaps perceived lasting benefits of this partnership going forward? And I'd like to give everybody just a minute to answer that. So Mike, could you perhaps start?
Yeah, lasting benefits. I mean, the relationship with the university, the county, the city, our community-based organizations is 300% stronger than it was going into the pandemic, and that will only bring benefits in the long run. One of the prior speakers, Timothy Murphy, noted how pre-existing relationships are so crucial. That is absolutely the case here, and I have 100, like I said, 300%, confidence that we will be that much better positioned the next time we are faced with a challenge, public health or otherwise.
Esmeralda, anything you want to add? Unmuted.
So sorry about that. Okay. I really want to bring into focus maybe wastewater surveillance. And I think that moving forward as we progress into this third year of the pandemic, and as COVID antigen tests become more popular, the public health department is going to have to rely less on COVID antigen testing reports. There's a lot of issues with that. There's health equity access, access, who has access to COVID antigen testing? And then are residents willing to report their results to public health department? So as we continue on with this pandemic, wastewater surveillance is very key to being able to monitor COVID levels and new COVID varieties coming into the communities. So it's definitely a partnership that will keep moving forward.
Thanks very much. And we do plan to continue to monitor wastewater through the end of the calendar year in 2022 around the region. Garth, anything you want to add, especially around students and even underserved populations that are within your community?
Thank you, Todd. I would say that through this partnership, we were actually able to make connections with members of the child care community. Our office serves as the backbone organization to the local child care planning council. And as a result of HCT procuring 600 air filter units, we were able to distribute those in partnership with First 5 YOLO. And so those relationships were not in place as strongly as they have become now. And so that we'll be building on that going forward.
Thanks very much. Dr. Marshall, you get the last word here.
Great. We know that our safety net has holes. And I think what we really learned in this process is then when we bring resources together, we can do more. And I know that going forward into the future, if we even think about wastewater surveillance, I believe that Todd will reach out to me and we will text message people in a certain zip code, our patients, to alert them and to give them access to testing. So we will leverage these relationships to do the best for our community.
Thanks very much. With that, I'll really thank the panelists. Really appreciate not only participating in this panel, but all the work you have done with us over the last couple of years. And I'll hand this back to Judy.
Yeah, thanks so much. Thanks, Todd, and to all the panelists for sharing the great work that you all have done. And I just want to call out in the chat, folks particularly resonated hearing about humility and how important humility is in these relationships. And also, I've heard a lot of adaptive leadership through your relationships with one another and your partnerships. So thank you for sharing your terrific work. And now we're going to move to our next spotlight. And you'll notice we've been moving from east to west here. And so now we're going to go farther west, but we're going to go north to Alaska and spotlight a program developed by a team of Alaskans to help answer wastewater challenges in underserved communities. The MiniPass, or Portable Alternative Sanitation System, has been tested throughout the state and shown to assist in bringing indoor hand washing sanitation and fresh water to homes that do not have running water. So our speaker for this spotlight is Jackie Catalina Schaefer. She is the Community Development Manager of the Alaska Native Tribal Health Consortium. Jackie, wonderful to have you, and over to you.
Thank you, Judy. And welcome, everyone. Owangadjiga Catalina. I am Jackie Catalina Schaefer. I am back from the northwest coast of Alaska. And I am going to share with you real quickly a project that has been just the inspiration for all of us in rural Alaska. Next slide, please. The project is a portable alternative sanitation system. We call this the MiniPass because it is a smaller version of a system, an in-home system that we use throughout rural Alaska for communities that are not served with water and sanitation via pipe system. So Stebbins is a small community, Yupik and Inupiaq, along the northwest coast, north of Nome. And this community has never been served with water and sanitation. Next slide, please. And communities that are unserved haul their water every day to their homes. And these photos share that story. Clear Lake is a volcanic lake that has very good potable water. They pump the water out of that, and then they pump it 2 miles to the village. In the village, they have a water treatment plant, which is their watering point, and they haul the water in these 33-gallon garbage cans. You can see how they line the garbage can. You know, they're brand new. They're used only for water. And so they haul the water on dirt roads, either with all-terrain vehicles, which we call four-wheelers, or in the summer. And then in the winter, they use snowmobiles. Next slide, please. So we had to work quickly when COVID hit and come up with a solution, because in communities that don't have pipe systems, the CDC was encouraging everyone to wash their hands. And if you don't have access to water, how do you wash your hands on a regular basis? And so this little system has two components. One is the hand washing station, which has a 25-gallon holding tank, and then it's gravity fed to a sink that sits below in the cabinet. So customers get to use clean water and wash their hands all day long. This actually washes, if you do the 20-second rule, we have at least 200 washes per 25-gallon tank. And then it flushes into a 5-gallon bucket underneath the sink, which then is, that waste is carried out outside the home. The second component is a vented honey bucket. And a honey bucket is not where you store honey. In rural Alaska and unserved communities, honey buckets are 5-gallon buckets that human waste is collected in. And we have a lot of challenges with that, a lot of health disparities in communities that use this system. This particular system uses a small fan to pull the moisture and the air out of that honey bucket, and therefore it eliminates the smell and the need to mask the smell with chemicals. But it also pulls moisture out, so it's less waste to haul outside the home. You can see here, even if you're in a wheelchair, this is an elder, they use, you know, it's on a dirt road, so it's a little more challenging than, say, a urban setting where we have paved roads and maybe handicapped vehicles that will escort our elders to the watering point. Next slide, please. The biggest success is building relationships, meeting people where they're at. These are people rich in culture, and these communities inspire me every time I visit them. The elders are wonderful partners. So we have a flow of network to make successful relationships. And that network starts with our tribes. In our tribal communities, we have 229 tribes in the state of Alaska. And our regional hubs, which are placed across the state, they have regional hospitals in those hubs. In this case, it was Norton Sound Health Corporation, and utilizing them to reach out to the tribe in Stebbins. And then the tribe chose which homes were going to get them. And in the tradition of our rural cultures, elders and children are served first. And so in this case, the elders were served. And you could see by the looks on their faces that because of this, you know, the community is so grateful to have their elders have this hand washing station and this vented honey bucket. And they, you know, they look at it as a stepping stone towards a pipe system. But the building relationships and meeting people where they're at are really, truly the success of projects like this. And I just want to say thank you for inviting me and sharing this project with you. We do have a video link that will be placed in the chat that has even more images and a little more about the story and the project itself. The project was funded by the CDC Foundation through a private donor, and we are so grateful to have had this opportunity to serve our rural communities with a portable alternative system. So, and thank you very much.
Well, thank you, Jackie. We really appreciate you sharing this fantastic project with us. Lots in the chat, a lot of excitement about this project, and folks that want to borrow from it and take it to other communities. Fantastic engineering, and love the relationships. So now it's time for us to go to another quick poll. And our next poll question is, how has your organization taken action to build or strengthen partnerships between business and public health? And again, it's one answer, but if you'd like to go to something other than the answers given to you, you can check other and go to the chat.
Judy, we're actually letting people select their top 3 on this one.
Oh, sorry, top 3. Oh, really? Okay, well, I
Yeah.
have to read my notes down. All
Mixing
right,
it up.
so has your organization, okay, top 3 on this one. There you go, bonus question. Top 3, how has your organization taken action to build or strengthen partnerships between business and public health? So we're looking at the business relationships here. Give you a little more time to answer. It looks like our technology is working now, so that's good. Okay, do we have results? Oh, here we go. It did work. All right. So 60% established relationships to identify collaboration areas, and right behind that at 59% promoted public health messaging in partnership with business, healthcare, and so forth. So those were the 2 leads. Looks like it's pretty distributed, however. So thank you all for those answers. And now we are going to move into our last panel of the day. And this one is focused on engaging the business sector in public health partnerships. We have another participant question you can start answering in the chat as we begin this panel. And I'm pleased to turn the podium over to our moderator for this panel, Ray Cairns, who is the CEO of the Next Solutions Group. Ray, thank you for joining us, and over to you.
Thank you, Judy. It's great seeing you, and what a terrific day it's been so far. There's been a lot of great collaboration and conversation here. So look, we're real excited for this next panel. I want to introduce our panelists before we go into our objectives. Our panelists come to us from different walks of life, and we're going to be talking about engaging the business sector. And I appreciate that last question leading us in, because ultimately I think we have learned over this pandemic is that when we work together, and Tim talked about it from an education standpoint, working with cities, we work together, we're much stronger together than we are individually. So first up, Stephen Massey, he's from Meteorite and the Health Action Alliance. Deb Salas Lopez is from Northwell Health. Soraya Rodriguez Montenegro is from Uber. And Anna Novus is from the Rhode Island Office of Health and Human Services. Our objectives for today is to demonstrate the critical role of multi-sector partnerships that include business in achieving healthy and vibrant communities that benefit everyone. Provide successful examples of work and action to engage the business sector, public health partners, and the local community. And finally, to highlight the opportunities to bring together businesses, public health, and communities, as well as challenges to overcome in establishing these partnerships. And so without further ado, we'd like to get directly into our conversation with our panelists. And so let's start, Deb, with the first question we'll throw to you, which is, please share your thoughts on some of the most successful public-private partnerships in the public health space that you've been a part of, and frankly, what have you learned from them?
Thank you, Ray, and thank you, Judy, and the CDC Foundation for inviting me to be part of this panel. So far, what I've heard since the start of the plenary, it's been terrific. I'll share one example. In 2019, our system recognized in one of our communities that we needed to provide better education around prevention, about healthy eating, healthy how to take care of chronic conditions in the community through healthier lifestyles. And so we were looking for where do we locate a Center for Healthy Living that would be embrace the community, would be available for transportation, for public transportation. And we looked to put it next to, frankly, one of our supermarket chains in the area. And what evolved from that was that we not only put in a testing kitchen and provided education around food and healthy eating, but working with our Whole Foods partner, that was the supermarket next door, we started to provide guided tours on how to shop for foods and how to read labels. And that collaboration then flourished, where Whole Foods came to us and said, we'd like to provide access to our employees to this, not only education, but also access to primary care. I'll share that now in 2021, we now have a deep partnership with our Whole Foods partner, in that our Northwell Direct, which is one of our subsidiary, is now offering an insurance product that we offer as part of a choice for Whole Foods employees to engage with us in healthy eating and prevention, primary care, and of course, how to take care of chronic conditions. So as you can see, and what was said before by some of the speakers, you start where you can start, you build the relationship and trust, you gain and measure success, and you build on that, all within the context of not only community, but public and private partnership. Thank you, Ray.
Thank you, Deb. Right, let's go over to you. Uber, what is Uber doing to advance public-private partnerships, and what are the successes you've seen?
Well, thank you for having me here today. I'm very excited to share with you what we're doing with Uber Health. And to answer your question, I first want to explain what is Uber Health mission, and is to enable equitable access to care by matching supply with demand through technology and surfacing those customers who may require intervention. Uber Health is basically a secure web dashboard or IPA solution for healthcare organizations to arrange and pay for rides on behalf of others using the same on-demand partners as Uber. Riders don't need to have the Uber app or even a smartphone, and they get text and phone calls about their rides. Second, I want to highlight the 3 successful partnerships quickly that we have been working on. The first one is Rides for Moms. That is a program that we launched with Surgo Ventures, Community of Hope, Mary's Center, to provide free transportation for prenatal and postnatal care appointments for up to 1,000 pregnant people in the Washington, D.C. area. A lack of good transportation option is a major challenge for many pregnant people and to access care, and Rides for Moms aim to address it. The other one is last year's partnership with the White House to provide free rides to vaccinations sites across the country. And on that same topic, we also established a creation of the vaccine fund in partnership with LISC, PayPal, and Walgreens to allow people to donate rides for people to get vaccinated. So those are partnerships that we are very proud of, that we see the impact each day for different communities.
Thank you, Zoraida. When we talk about public-private partnerships, there's oftentimes a reluctance for public health and business to work together, even though we've seen some great examples during COVID. Can you talk, Steve, I'm gonna call on you next. What are the key elements you think there are to have successful public-private partnerships between public health and business?
Yeah, well, thanks so much for having me here today. It's just to quickly introduce the Health Action Alliance is a really unique initiative of the Ad Council, Business Roundtable, CDC Foundation, the De Beaumont Foundation, the National Safety Council, and the Robert Wood Johnson Foundation. This group of organizations that's really come together to help employers navigate evolving health challenges. And I think over the past year, we've really come to understand that businesses need free resources, support, and training to help them strengthen their response and collaborate with public health. I think what we've learned during the pandemic is that it's abundantly clear that business is part of the public health system and that public health really directly impacts business. So we really should harness, I think, this unique moment in time where there's alignment between business and public health to reduce the risk of future pandemics and other public health emergencies by continuing to strengthen the health and healthcare infrastructure in local communities. The past 2 years, many businesses have worked with local public health departments and cultivated new relationships with public health leaders. That's muscle memory that should continue to be exercised and not forgotten. Even as businesses begin to pivot to a post-emergency phase of COVID-19, there's really critical work to be done to rebuild public health in local communities. And now is the time for business and public health leaders to work together to build a stronger future. It's also important, I think, to underscore that the American people really trust and expect businesses to take action on public health. According to the Edelman Trust Barometer, 77% of Americans trust their employer more than any other institution. And employers were second only to physicians as the most trusted source of information on COVID-19 vaccines. Workers also expect businesses to take action on health. In fact, 4 in 5 Americans want their company to lead on health issues. So this is a really unique moment where business, public health, and the American public are aligned. Businesses acknowledge that they're part of the public health system. There are new relationships that have been developed during the pandemic, and there is broad support from the American people, including the employees and customers that drive business growth and revenue, that businesses should take action to strengthen the health of employees and their families and contribute to stronger communities. So I think it's an important moment in time where we're aligned and we can continue to build from here.
Thank you, Stephen. Very, very helpful. And can we talk about, on the same topic, there are obviously pressures. There are pressures from all sides. In fact, I saw some of the chat commentary going by in the last panel. We're talking about how there was sort of a collaborative view towards what success looked like. What do you think are the pitfalls and the pressures on trying to put together these public-private partnerships?
Did you call on me?
Yes, Anna, sorry.
I wasn't sure. So good afternoon, everyone. My name is Anna Novaes. I'm the Assistant Secretary at the Rhode Island Department of Health. And I think when I look back at the kind of initiatives and partnerships that we've had here in Rhode Island, one of our, I would say, success stories is the fact that during this COVID response, we had already established relationships with the business community. We didn't start from scratch. We recognized a long time ago that business were a critical partner that we needed to engage with. And so one of our key initiatives that's called the Health Equity Zones, it's truly a community driven by local communities. It's a collaborative. And they had a requirement from the Department of Health and from the state from the get-go to engage with business as part of their key partners in that collaborative. One of the things that we've learned is that many times we need to learn each other languages. That collaboration is not easy. We speak public health, they speak business. And when you start having that conversation without taking the time to build a relationship, learn each other languages, and just jump into that relationship, it doesn't work. And so we need to learn how to translate our public health stories and lingo into a language that they understand. And I think once we can meet each other in that same common space, there is less resistance that one can think, because we, both of us, understand how much we need each other. And most of those examples so many of the examples that we heard today are reflective of that needing to work together, collaborative. And COVID, as Stefan was talking about, showed us more than ever that we could not achieve the results we achieved if we didn't have that relationship and didn't commit to learn how each other do the business of improving people's health. We did that with the way we talked testing with the business, the way we did guidance to business. So we needed to adjust. And as public health and as health and human services, we took the time to respond to that and understand the pressures that the business have, but at the same time have business understand the science behind some of the guidance that could be perceived as difficult or non-for-profit, non-for-business. And if you sit down and have those kind of conversations, I think a lot of that resistance goes away.
Very, very well said. Deb, I'm going to turn to you now. Northwell Health is obviously one of the largest health systems in the nation, definitively in the Northeast. I mean, I saw as Anna was speaking, you were nodding in total agreement. Do you want to expand a little bit further on that?
Sure. So Northwell Health, we're the largest health system in New York State. As many of you know, we were the center of the epicenter during the pandemic. We learned a lot. And as Anna just said, we learned first and foremost that we have to do this together. Our public, our private, our CBOs, our faith-based organizations. It was only because of that partnership ecosystem that we succeeded. And so understanding that and understanding how important that is, that relationships take time to build, as does trust. Learning and listening, I think it was Pastor George who said, really listening, because we have a lot of data. We had a lot of data on what happened during the pandemic, but it wasn't until we went out into the community and really listened and paid attention, seeking first to understand that we can then co-create community solutions, and we can bring other stakeholders, private stakeholders to the table and others, public stakeholders to the table. That was a real learning for us. Certainly, I think that building on that now over time and being patient with what are the solutions, not jumping into solution jump, but rather it's not for the community, it's with the community. And so doing it together in ways that make sense, where we have a common vision and mutual goals, was very, very important for us. And over time, now building on that, and as was said by the previous panel, knowing that we can use this now as a foundation to build even further is, I think, going to be very important. So we can focus on the longstanding disparities that we've had in our communities and the inequities in care and so on.
Thanks, Deb. Right, next question is for you. I want to bring us now back to the actual pandemic in the early days when there was just so much non-information. I mean, there wasn't enough to go. People did not know what was happening. And there was a whole conversation about which workers fell into which class. And there was a huge conversation related to the drivers, particularly from Uber, and which class they actually fell into. And I just, you guys have had so many great partnerships throughout and did so many great things throughout the pandemic. Can you just share with us, what have you learned through this pandemic, particularly as it came to engaging society and community? Because again, so much was unknown, but yet you engaged regardless during that very difficult, tough time with lack of information. Any insights would be greatly appreciated.
Thank you for your question, Ray. Well, I couldn't agree more with the other panelists, with Debbie and Anna, in terms of we need to listen to each other. We have to understand each other and find common ground. We work with different organizations, with the CDC, et cetera, to listen to the guidance, and we had to react quickly, to accommodate quickly, and try to do with this guidance what was best for drivers, for riders, for everybody. And we have been very good in adapting and changing as things have changed as well. I think another thing that we have learned from these partnerships and outcomes is we have to design solutions that take into account how healthcare is delivered to underserved communities, and plug in transportation at the right point in service delivery in a way that solves barriers to access and serve the target population. You have to take into account and consideration other things like language, access to tech, financial barriers, how rights will be given, at what point should they be given, etc. So those are one of the lessons. It's listening to each other and trying to understand where can we contribute and how we can collaborate with public health officials and serve the community.
We've got two more questions to try and get to, and these next two, we're going to ask each for our panelists to weigh in. And we're going to start with you on this one, if you don't mind. There's been a lot of conversation here with, and again, I'm watching the chat as we're having this dialogue here, and the continuous of the collaboration and the inspiration that comes from working together in this whole in area of public-private partnerships. How can we keep this collaborative spirit going? We have learned so much through this pandemic about how to work together. But Anna, the question I throw to you first is, how do we keep the collaboration spirit alive?
By continuing to sit down at the same tables, by understanding that the work is not done. I think we are so quickly moving that we are done with the pandemic, but we are not done with recovery. All of the social and core root causes of inequalities that were exacerbated by the pandemic, they are still here. We did not resolve them. We have this unique opportunity in time with all of the funding coming to states, coming to business, to truly have the conversation. Are we going to be transformational on how we respond to the post-pandemic, or are we going to go back to business as normal when that normal wasn't good enough for so many of our communities and those that we serve? So one of the commitments that we are taking here in Rhode Island, it's having conversations now, the same approach we had on terms of whole of government and all integrated approach for the recovery efforts. What does that mean to go back to business? What does that mean to reopen the restaurants? What did we learn from these past months? The new tools, new approaches that we want to continue to be in place. It's forcing ourselves not to be quick to go back to business as normal, but to learn from this pandemic and engage with each other in those conversations. One of the things people had told me once, a business partner, was, don't come to me with an ask for money or resources because I'm business. Come to me and tell me, what do I bring to the table? What do you bring to the table? And how can we help each other? And continue with that same mindset as we move forward, and recognizing this time in history that is for all of us. We're not going to go back to 9 to 5. We're not going to go back. We learn to work remotely in ways that our culture in the United States would probably never have thought about. All of little and big things that we need to continue to engage together. We owe it to people.
Well said. Thank you, Anna. Debbie, over to you. Deb, we're going to roll to you now, if you don't mind. Same question.
Sure.
How to keep the spirit alive?
You bet. I think Anna's absolutely right. Let's build on what we've already done, and let's look for the next COVID issue. And I'll give you a concrete example. During the pandemic, the pharmacy chains, Walgreens in particular in our market, got the vaccine. We knew we had to go into communities that were disproportionately affected, minoritized, underserved communities, to make sure that there was an equitable distribution of the vaccine. We engaged Walgreens. They brought the vaccine, their partnerships. You know what we did? We built on the relationships we have built with the faith-based leadership, and we brought them into the churches where disproportionately our Black, Brown, and Latinx communities have been affected. We've now built on that partnership, and we've signed a strategic affiliation and partnership agreement with Walgreens, between Northwell and Walgreens. And now we're looking to look at the issue of maternal health, particularly in Black, Brown, and Latinx moms. And there's a donation that they've given us, 1,000 bottles of baby aspirin, so that we can put it in some of our practices to see if we can move the needle for high-risk moms. Again, incrementally building on that great foundation that COVID, unfortunately, COVID was with us, but we're building on that now to see what's the next issue that we're going to tackle together. Our faith-based, we have a leadership forum next Tuesday with our faith-based leaders around mental health, because we know the community is telling us that that's a big deal in the community. We're engaging not only the community, but we're also engaging our private partnerships to work with us on a common vision, on common goals, with solutions that are co-created in the community. So building incrementally, now that we're both at the table and we realize that we need each other, what's the next issue that we're going to tackle together in ways that make sense?
Sure. Thank you, Deb. Stephen, over to you.
Yeah, thanks so much. And I would really want to underscore everything that Anna, Deb, and Zoraida have said. I think there's been really helpful feedback in this conversation. One of the additional ideas that I would just offer is that I think it's important that we all begin to talk about the ease of developing these relationships rather than how hard it is. Because when we keep reinforcing that something is hard, it makes it more challenging for us to get started. And at the end of the day, we're all people, and building bridges between business and public health is about relationships. And many great relationships between business and public health were established or strengthened during the pandemic. So if we talk about these as valuable and easy to build, it makes it more palatable for leaders on business and in public health to begin to work together. Relationships at the end of the day are about building trust, about speaking the same language, and about aligning interests. And I really appreciated how Anna and Debbie talked about about speaking the same language and making sure that public health leaders understand the language of business. The flip side is also true. Businesses right now are really struggling to hire, retain, recruit workers. That's the language of business. And if public health leaders can come to business with solutions that will help businesses have healthier, happier workers, you will be speaking a language that will really land favorably for business. And that's why I know Deb is thinking about mental health as an issue in her community, because that is an issue that business leaders have flagged as a critical priority for them and for their workers. Finally, I also just want to applaud companies like Uber. Zoraida has been a real public health leader during the pandemic, and she sits inside of a private enterprise. We should celebrate companies like Uber that have taken bold steps to engage with public health, to activate their own resources and their own strengths to support the public health response. They are champions and great examples of what's possible when business and public health come together. And I think many more companies will be inspired by that kind of leadership as we look to the future.
Thank you, Stephen. Right over to you. Keeping the collaborative spirit alive.
Well, thank you for the opportunity. Thank you, Stephen, for those words where, as you said, we try to do something that is core to our business. Sometimes when you do things that are core to your business, and ours is to remove transportation as a barrier for getting to vote, for healthcare. So you can do a good impact and a great impact if you stay true to what you do best. And for us, it's transportation. And on that, it's important to highlight that relationships are very important. As Stephen said, we're all people and we can just try to find that common ground. But decision and planning is also key from both sides. When you want to do an initiative, it's important to connect early on, establishing the goals early, and having those goals during the entire planning will help you to achieve them. Discuss the implementation process, spend time figuring out the details of the things that you want to do, and then contact the business that you think fits better your needs to plan this your initiative early on.
Excellent. Thank you. Okay, panelists, we now enter our lightning round. We each have about 30 seconds here now to give your final thoughts, but I'll at least pose a question because we've touched on a lot of the same topics related to engagement and education, partnership and collaboration. So that's a setup for all of you. Ultimately, at the end of the day, what is your final passing thought here for those who have been attending here today related to the message to all those who are looking to put a public-private partnership together? What are the final commentary you'd like to offer up? I will start with you, Stephen.
Great. Well, again, thanks so much for giving me the opportunity to be here today. I'm going to speak to the businesses that might be on today's call and really encourage business leaders to understand the current state of health in the communities where you operate and where your employees live. There's been, obviously businesses spend a lot of money on health and healthcare for their workers, but it turns out that a large portion of an employee's health and wellness isn't determined just by the health benefits that you offer, but it's actually determined by the community in which those employees live and work. So understand what are some of the critical needs in your community and reach out to your local public health officials who are actively tackling systemic issues in your community and are willing partners. It's also important to just connect your company's corporate social responsibility efforts to your community health needs. And again, your public health department and public health leaders can help you identify areas where those types of investments can really be maximized. Finally, I'd encourage businesses to really advocate for public policies and investments that will improve public health and help rebuild public health institutions after the pandemic. And finally, stay connected with other businesses in your community through your local chamber of commerce, with public health leaders. Relationships take time to build, but it's critical to be connected and build on the momentum from the pandemic to create a stronger future.
Thank you, Stephen. Anna, over to you.
I will speak from a public health perspective and to my colleagues in public health and let them know, don't be afraid to look at your business partners and see them as a key partner. The same way we are used to deal with housing, with education, business is an equal partner. Take the time to learn their language and to not be there with, I know it all, that we so much in public health have a tendency to do. We have all of the answers, we have all of the data, but we don't have the total story. So a little flexibility and humility from public health in our approach to business and how we engage with business is important. The same way as we do with the community. We recognize the power of our community partners. We agreed, at least in Rhode Island, to seize that power and really elevate the voice of our community partners. Just think that your business partners are one of those community partners. And the same way we are engaging people and we are elevating people, local municipalities, let's also elevate and bring the same humility, the same effort to learn the language and meet people where they are as we do it all other partners and issues. Let's challenge ourselves and keep doing it with business. We need them and they need us.
Thank you, Anna. Farad, over to you.
So we are very, very limited on as a business to do things unless we partner with communities and we partner with public health officials. So we're here, reach out. We are also doing things proactively, but we look forward to connect with many people and be able to be part of your initiatives. We have a very dedicated Uber Health team internally that will love to connect with any one of you. So that will be my final thought for the
Thanks, Ryan. Debbie, final word to you.
Final word. So first, thank you, Ray, and thank you to my co-panelists. It's been a pleasure getting to know you and being here. I just want to emphasize everything that's already been said. Seek first to understand what are the community needs. And I'll speak to both the public and the private partner. Find a partner with a common vision that you can establish common goals with. Co-create, include the community in that co-creation. Measure and share success. And then finally, refine, renew, and continually reflect on what's happening in the community. Because the pandemic did teach us one thing, that things can change drastically and quickly. Thank you.
Thank you, Debbie. And panelists, thank you all very much. It's been an absolute honor to be a part of this panel. Judy, I will turn it back to you.
Well, thank you, Ray, for your excellent moderating of this panel and for the terrific wisdom coming from the panel. A lot of really positive remarks in the chat. I think folks appreciated. I saw one where they were talking about the public health needs to learn the language of business, which would be very helpful. So learning from one another. And I wanted to comment on, I think it was Deb that said, she mentioned the partnership ecosystem. And you all spoke to having this ecosystem that is healthy, a healthy ecosystem, that you normalize it, that it's easy to have the partnerships. I love those comments. So again, thanks so much. And now, I have to say, it's kind of difficult to believe, but we're really entering now into our final session of today's summit. And I'm very pleased to bring in for this session Dr. Eduardo Sanchez, who's the Chief Medical Officer of the American Heart Association and Principal Investigator of the National Hypertension Control Initiative. He earlier served as a state health officer, and he has served as a local health official in Texas. So he brings a community perspective, public health perspective, and so we'll be in a conversation with Eduardo here at the end. So Eduardo, pleasure to have you join today. And our role is really to kind of sum up and emphasize some of what we heard today. I'm very anxious to hear your response to the questions. Eduardo, if you don't know him, he brings a lot of energy and a lot of wisdom to this. So Eduardo, let's kick this off. You have years of experience in partnerships. And so thinking back to partnerships in the COVID-19 pandemic, what do you think we need to do to build upon lessons learned and the partnerships that have been built going forward? And how do we translate these learnings actually into action for our audience?
Well, let me start by thanking you for the invitation. I am humbled, truly humbled. I think the session today was just so amazing. The wisdom of the speakers, the panelists, the moderators, but also the chat wisdom. And that's the reminder that there is wisdom in our community. And I loved how almost every panel talked about how we need to listen and listen to that wisdom that comes from our communities. I also can't help but think about the fact that there were at one point about 1,400 people that were participating. In my mind, that probably translates to tens of thousands, if not hundreds of thousands that are committed. But it also says we got some work to do to get millions thinking the way those who are participating today have been engaged. And it also suggests to me that we've got lots of organizations also that we can reach out to and bring into the discussion that we're having. Last, I think the sentence I heard that is going to resonate the longest for me is that the work is not done. And so let me answer the question. The COVID collaborative, the COVID pandemic, led to a number of things, and many of us who wanted to do things, found others who wanted to do things, came together and acted. We heard a little bit about that today. I have the great privilege through the American Heart Association, and I see so many people on here who are participating with the COVID Collaborative, which I thought exemplified some of the very things that we've been talking about. Diversity in terms of a national advisory council, a small staff that was getting things done, a diverse group of collaborating organizations that committed itself to making a difference and doing it in a way that was thinking about meeting people where they were. The relationship part was a little bit hard because we were in the midst of a pandemic, but the fact is that there was some of that relationship building work that was done. Data drove a lot of what happened. And I think that the COVID Collaborative brought home to me an important message, which is that messengers matter, messages matter, and the meeting place where the message is being delivered or the service is being provided absolutely matter. And we've heard many stories today about how that was brought to bear, whether it was the PASS system in Alaska or the work that's been done in Yolo County, where figuring out how to meet migrant workers where they were. I love the story about the woman who chose to speak English. That is about meeting people where they are and building relationships even fast. And I think that what we want to do is build on and build from the COVID Collaborative. I wrote some words down and I borrowed from the motto of the COVID Collaborative. And what we want to do is maybe change the motto to, we believe a united America can protect and promote health and prevent or delay disease. And what we need is instead of a COVID Collaborative, we need the Public's Health Collaborative. And I said it that way on purpose. I do think that when we say the words public health, people what it conjures up is this image of a government organization. And really what we're talking about today is the public's health. And what can we do collectively to protect and prevent and promote the public's health?
That's awesome. You're getting a lot in the chat. Folks are very excited to hear you say that, and I think that's spot on. Absolutely. So I want to move to systems level change. You've worked in systems level change. Talk to us. What are your thoughts about the keys to activating cross-sector partnership that's going to really facilitate system level change?
Well, I think we heard so much wisdom today about how in Buffalo that has been done, how in Yolo County, Davis that's been done, how it's been done in the Northlands of Alaska, and so many other places that were covered around homelessness. I think I heard over and over again different ways of describing systems change. A few things that I think I heard: authentic commitment to that change is really important. But even that authentic commitment to that change involving the notion of humility and flexibility. We all go into things thinking that we know what the answer is. And we all of us need to be able to listen, stop for a second, reflect maybe, and perhaps change direction a little bit in the way that we're thinking about things. So authentic commitment to affect change, which equals intentionality, and then doing the things that have to be done. Got to say, I heard so many words that just the words themselves are 5 or 10 minute conversations to be had. Time and commitment, people and partners. I didn't hear this word, I don't think, but representativeness as diversity, inclusion, and voice. Facilitation, oh my God, that one is so important. So when we talk about resources, it is not enough to say we're going to organize the meetings. It is about facilitating. It is about summarizing. It is about engaging with folks about, is that actually what happened in our meeting, and moving a process along in a very intentional way. So I think I went above and beyond the systems change, but I think the word that I would use that I learned, so one of the things that happened when I was running the state's health department with 14,000 other people, gotta say, is that I was involved in a systems change where the traditional public health department became an Uber organization of public health, mental health, and substance abuse organization. Change management is critically important. And as we think about systems change and we think about collaborating with businesses and communities, and actually I agree with the notion that we should be, that's an and, that's not a one thing and another thing, it's one thing all. But as we do that, we need to keep systems change and change management in mind. And I do think another, for those who are the pediatricians out there, anticipatory guidance is the greatest term ever in terms of helping people understand what is likely to happen in a process. Really helps us all move our way through that process.
So well said. So you are getting a lot of applause in the chat. We have come to the end of our time. So Eduardo, thanks so much for joining. We won't be able to get to all the questions I had planned, but you really covered, I think, in your answer, everything. And thanks for ending us on such a inspirational note.
Thank you for having me.
Now,
again, Judy, just inspired by all. Thank you, Judy, and thank you for your leadership.
Well, thank you. Thanks, Eduardo. So now I'm going to take just a moment to reflect on the initial 4 summits in the Future of Public Health Summit series. These 4 summits, which started in December, have been enlightening and I think for many, cathartic. But our work's not over. It's really just the beginning. And I want to again highlight that this summit series, we've been able to build on the great work of so many individuals and organizations engaged in the public health sector for many, many years. So together, what we've been able to do through these 4 summits is look at learnings from the past to plan for the future. And I'm going to steal the chat wisdom that showed up in the chat today. I think we've had a lot of chat wisdom, or really a national conversation. So since this, as a central event informing much of our conversation, of course, has been the COVID-19 pandemic, which provided the latest reminder of the vital importance of public health and need for a future-forward, future-ready public health system. In this first summit, in the very first one, we focused on the all-important topic of achieving a diverse and robust public health workforce. And as Dr. Walensky put it then, having the right people in the right place with the right training at the right time to protect Americans from public health threats. In the second summit on data modernization, we underscored the need for investment in and the development of comprehensive, flexible, and interoperable data systems to track and address both chronic health challenges as well as future infectious disease outbreaks. The third summit zeroed in on public health law, governance, and finance. We discussed how governance provides the context for how public health functions in a jurisdiction, while public health law provides the legal guidance and authority required for healthy communities. Financing supports the skilled workforce, the state-of-the-art science and laboratories, the forward-leaning programs, in essence, the mechanics of public health. And we emphasize how we must build toward a future where law, governance, and finance work together, or else we run the risk of ongoing tension and less effective systems. So today's 4th summit on cross-sectoral partnerships and community engagement really provided a great opportunity to think about how we work together across all sectors to create healthier, vibrant more equitable, and more resilient communities. So as we close out, I do want to thank all of our speakers, moderators, and panelists for the great job today and throughout all the summits. I want to thank our co-hosts, ASTO, NACCHO, and Big Cities Health Coalition. Importantly, I also want to again thank our partners, United Health Foundation, Robert Wood Johnson Foundation, and the Pew Charitable Trust for their support of the Lights, Camera, Action Summit Series and making this possible. And I thank all of you for being a part of today's 4th Summit. So looking ahead, our team will work with many of you to continue building on what we've heard. There will be recordings, reports, action briefs to guide our next steps and much more. And who knows, we may want to bring us all together again for other summits in the future on topics that are central to the effectiveness of our public health system, our nation, and the health for all. So thanks again for your participation and all of your contributions. I wish all of you great health. And once the meeting ends, a brief feedback survey should pop up on your screen. Your feedback from previous summits has been very helpful to help us improve how we organize the summits, and we hope to continue learning from you in terms of what works best. Please take a couple minutes to respond to the survey, and you can also send other feedback to futureofph@iphionline.org. If you've received an invitation to small breakout groups, please find your Zoom link and join us at 2:30 p.m. for the deeper dive in the small breakouts. Again, wishing all of you good health. Thank you for all you do. And that's a wrap.